Good afternoon, everyone. My name is Tram Tran, and I am a medical officer and physician hepatologist here in the awesome Division of Hepatology and Nutrition at the FDA. I'm a former medical director of liver transplant at Cedars-Sinai Medical Center and professor of medicine at UCLA. I'm super happy to be hosting this afternoon with Paula Cappuzzino. The afternoon session, I think, is going to be super fun because we're going to be really talking about things that I think are relevant to patients, that more accessibility in regards to circulating biomarkers for non-cirrhotic NASH clinical trials. So with that, I'd like to introduce my co-moderator, Paula Cappuzzino.
Hi, good afternoon. I'm also very happy to be here. I'm Paula Cappuzzino. I'm currently the acting deputy division director for the Division of Chemistry and Toxicology Devices in the Center for Devices and Radiological Health. I'm here because we regulate certain biomarkers for liver disease. Little background, I got my PhD in 2005 in cell biology. After a little while at the NIH as a postdoctoral fellow, I came to the FDA, where I was a reviewer for about 8 years. For 8 years, I was the branch chief for cardiorenal diagnostics, which also includes liver biomarkers, and that brought me to my current position. So I'm very happy to be moderating, and I hope that we have a really good discussion today that can really, help move this field along some.
Thanks, Paula. So the way it's going to work is I'm going to introduce our speakers, and then we'll have a panel, and I'll introduce each of the panel speakers, and they'll have 3 to 5 minutes to give us a perspective on some of the things that we're going to discuss today. So our first speaker this afternoon is Richard Sterling. He's a professor of medicine and chief of hepatology, chief clinical officer at the Stravitz-Saniel Institute for Liver Disease and Metabolic Health at Virginia Commonwealth University. He received his MD from Jefferson Medical College in Philadelphia, a master in biostatistics and clinical research from VCU in 2007, and then he completed his residency and fellowship in GI and transplant hepatology, also from VCU. He's published over 250 manuscripts, is super active in the prominent and in the committees of the national associations such as the ABIM, AGA, AASLD, and ACG, has won numerous awards for teaching, and I believe he is the first author of the practice guidelines for the biomarkers for AASLD. So I'd like to welcome and look forward to Rich Sterling, who's going to give us a talk on FIB4 and other circulating biomarkers. Richard?
Thanks, Tram. Can I have my first slide, please? Okay, so that's who I am, and I'm going to talk to you for a couple of minutes about the simple non-proprietary circulating biomarkers, particularly focusing on FIB4, the AST to platelet ratio index, or APRI, and the NAFLD fibrosis score, or NFS. And you can see I wear a lot of hats here at VCU. So next slide. I think one thing to keep in mind when interpreting these blood tests is that most of the tests have a lower and an upper threshold, where the lower threshold is sometimes used to treat those, or at least to identify and screening those with mild disease, F0 to F1, while the upper thresholds are used to look at patients for more advanced disease, such as F3 to F4. But the problem is that when you look at these upper and lower thresholds, there's usually a significant portion of patients that sort of fall in between in the indeterminate range. So next slide. So really, when you're looking at biomarkers, you really need to ask 2 questions. Next slide. The first question is, what is the negative predictive value of the test? And that's that's a patient cohort, or the patient that you do not need to necessarily worry about. And the next question, next slide, is what's the positive predictive value? And that's what we're going to talk about looking at today. Next slide. So when you look at currently available circulating biomarkers, they're often divided into 2 basic categories: the simple non-proprietary ones, which we're going to look at today, and then the more complex ones that are more proprietary. And you can see there's a whole list of them there. And what you're going to hear about next after my talk is looking at the Enhanced Liver Fibrosis Test, or ELF tests. But as you can see, the simple proprietary tests started with something in 2003, the APRI, and then the FIB4 came in 2006, and I'll just show you a little bit about how that was developed. And then the NAFLD fibrosis score was soon to follow. But there have been other scores along the way that we're not going to get a chance to talk about today. Next slide. So the only thing worse than doing a liver biopsy is teaching someone else how to do one or having one done on yourself. And that really led to the development of this FIB4 assay. Next. So when I look at what was there and the existing models prior to the FIB4, for example, in 2004 and 5, is that what we used the AST to ALT ratio, which we were all taught in medical school. We knew that low platelets were associated with cirrhosis, and based on some of those, the APRI was published in 2003, but that's really all we had. But based on the APRICOT database, which was a large data set of biopsy-proven patients with HIV-HCV that were being treated with an pegylated interferon and ribavirin, that was really the data set that we used to develop the FIB4 assay. And with the help of Roche, who sponsored that assay, they were able to provide a statistician. Next slide. And the FIB4 there is listed there. It's age and AST on the top and platelets in the score root or ALT on the bottom. And really this was developed to identify those with advanced fibrosis F3 to F4 from those with F0 to F1. So next slide. So shown here is the data from that original paper in Hepatology in 2006. And if you look at the predictive probabilities, the way that the FIB4 was developed, which is a little different than some of the others, is that we actually looked at three different fibrosis strata in the cohort, those with F0 to 1 versus F2 to 3 and versus F4 to 6. And this is looking at the training set of 555 patients. As you can see, when you look at the upper threshold, let's say a FIB4 index of 5, you can see there that the probability in the dark line in example 1 of having advanced fibrosis is pretty high, about 80%, whereas the probability of having F0 to F1, which is at the very top dash line, was only 3%. If you look at the lower thresholds, which is to rule out disease as an example 2, you can see the opposite, where if your FIB4 is 1, you only had about a 10% chance of having advanced fibrosis and a 60% chance of having minimal F0 to 1 fibrosis. And this was confirmed in the validation cohort also. Next slide. So if we look at how these serum tests perform, this is some unpublished data from the AASLD blood-based non-invasive liver disease assessment, or NILDA guidelines, which should be coming out soon. They've been in the process now for a while, but we're close to the end. And you can see here I compared APRI, FIB4, and then for comparison, I used one of the proprietary tests, which was either the FibroSure or FibroTest, which is the same test. And you can see we're going to focus first on the NASH patients. At the bottom, you can see that using lower thresholds for APRI of 0.5 versus a cutoff of upper of 1.5, that has a sensitivity of 78% and specificity of 96%. Similarly, if you look at FIB4, again, depending on the lower threshold of 1.3 and 2 upper thresholds, 3.25, or what's represented in NASH is 2.67. Again, you can see here the sensitivity was 82% and the specificity at either upper threshold was 94%. And you can see how both of these tests, the APRI and the FIB4, work as well as the proprietary tests, which you have to pay for, particularly in a NASH, where they have a specificity of 90%, but much lower sensitivities. Next slide. Now, that was for F3 to 4 versus F0 to 2, which is how those tests were originally developed. If you ask the question, how do these tests perform just to determine cirrhosis from everybody else, you can see here again for APRI using the same thresholds of 0.5 and 1.5. Here the sensitivity was 77% with specificity of 90%. FIB4, when you look at just looking at cirrhosis here, there's one cutoff of only a 1.9, and you can see here again, sensitivity 73%, but pretty good specificity of 89. And those again compare to the proprietary tests as listed there. Next slide. if you then ask the question, well, what about if you just want to identify those with significant fibrosis, F2 to 4, that would be potentially the population that might be eligible for clinical trials? Again, you can see using the thresholds for APRI, a cutoff of 0.5 only had a sensitivity of 74% and specificity of 72%, whereas with FIV4 and NASH using, again, the single threshold of 1.45, here again, you can see slightly lower sensitivities of 69%, but a little higher specificity of 80%. But again, these essentially two free tests work just as well as the proprietary tests, where there's really no data for NASH patients. Next slide. So FIV4 has been widely used since 2006. When I initially developed these slides over the summer, there were over 2,000 citations. Google Scholar had over 23,000 hits. And VCU has led the way with using the FIV4, both in viral hepatitis B and C with or without HIV, also in NASH patients. That original threshold of 1.3 and 2.7 were developed through the NASH CRN at VCU. But we've also looked at this index in patients with end-stage renal disease. And if you think that FIV4 only works for liver disease, it doesn't. There's plenty of data out that you can even use the FIV4 score to assess disease severity for COVID and need for mechanical ventilation. The FIV4 has been used in the guidelines for both Hep C guidelines. As I've mentioned, it will be in the AASLD NILDA guidelines, and it's also in the NAFL guidelines for AASLD, and as well as the diabetes guidelines. And in fact, FIV4 has been used so often that it's not even really cited anymore. Next slide. But that's not the only score. So shown here is, again, unpublished data taken from the AASLD NILDA blood guidelines, and this is for the NAFLD fibrosis score to predict F3 to F4. And this is, again, all the studies that we could identify at least until 2019. And as you can see here, the proportion of patients with F3 to F4 kind of varied with each study. So it could have been as low as maybe 10 or 11%, and as high as 28 to 30%. And you can see here the AURCs kind of vary. They could be anywhere from 0.53, which is in the Yang study from 2019, or it could be as high as 0.92 in the 2012 study. But I also want to point out that that's at the lower score. If you use the upper scores, the specificity will go way up into the high 90s. So again, it's a pretty valid test. But again, you can see that's a fair proportion of patients who fall in the indeterminate range, where these scores really don't tell you what's going on. Next slide. I think it's important to keep in mind, though, is that there are limitations to all blood-based NILDA, and that's shown here on this slide. And there are a lot of clinical conditions, such as age, things that might affect the platelet count, such as those who either have splenectomy and really high platelets, or thrombocytopenia from some other non-portal hypertension cause, alcohol use, acute hepatitis, kidney disease, systemic inflammation. Any test that includes bilirubin might be affected by hemolysis or Gilbert's. But you can see that there is lots of things that can cause these limitations of blood tests. So when you order a blood-based NILDA, again, all of them are listed on this slide. You have to then figure out how that's going to affect your results. Next slide. So there are certain limitations in clinical practice and in clinical trials, as I've mentioned. Up to a third or more could have an indeterminate result. We have very limited data on natural history of using these blood-based tests. For example, anything that includes age is going to go higher as patients get older. There's very limited data in response to therapy, and as was mentioned this morning, often you have reduced inflammation that leads to a reduction in your biomarker, but that doesn't necessarily mean that you've improved the fibrosis. There's really limited or no data about how to use these in hepatitis C patients after DAA therapy, particularly when you're trying to assess ongoing HCC risk. hepatitis B patients who have been suppressed, and of course, autoimmune hepatitis patients on therapy. I think that identifying those with F2 to F4, those eligible for clinical trials, I think you can probably identify who might not be a candidate. But I think, as we've heard from this morning, there's going to need to be some other test to figure out who might be a candidate for the trials. And of course, what magnitude of change that is meaningful and clinically meaningful is really yet to be defined. Next slide. So this is the unpublished draft guidelines of how we're going to use blood-based NILDA in clinical practice from the AASLD. So here, as you can see on the left-hand side, those with low values, again, depending on whether you have NAFLD or some other cause of liver disease, those are patients who do not have advanced fibrosis, and those be continually monitored. Then you have those with advanced disease, who again, depending on whether it's a NAFLD or non-NAFLD, is what threshold you would use for the FIB-4. Those might identify who might need more confirmatory testing, as well as all those patients in between. And as we'll hear about next, for NAFLD patients for confirmatory testing, you'll hear about how the ELF test might be used. And what we heard about this morning was about the use of liver stiffness, a measurement by whatever means that, that you have available. So next slide. There were several questions that I was asked, and I decided to break this up into evidence or eminence-based medicine, as I call it. And for the first part is, what test can these do well to detect? And I think F3 to F4, there is evidence that it can do that. But I think as a diagnostic or prognostic marker, it's much better for diagnosis. There is some data in some conditions like Hep B that a high FIB-4 predicts an outcome. But I don't think we have as much evidence of that in patients with NASH, but we'll hear about, again, how ELF might be able to fill that need. Next is, what are the limitations? And I think there are many, and I think there's evidence that there are many limitations to these simple biomarkers. As far as what value of a non-invasive test score or thresholds indicate a worsening of fibrosis, again, I think we don't have a lot of good longitudinal studies, so I put that in the perhaps with eminence-based. What about test results that may improve to the reduction of inflammation? And if a simple biomarker does show improvement, does that necessarily mean that the overall disease is improving? And I think, again, that's perhaps. What about the utility or the usability of the data prior to the changes in the more recent technology? And how can we tap into some of these older cohorts that have liver biopsy? And I think that is an opportunity, but again, that's eminence-based. And what magnitude of change is clinically meaningful? And there's really not much data to support that. So next slide. All right, so just to sum up my 15 minutes of fame here, due to the high specificity and very high negative predictive values, particularly at the low thresholds where the negative predictive values are over 98 or 99%, I do think the simple, non-proprietary, non-invasive liver disease assessments like the FIB-4 can, and I would say should be used as the initial test in all patients to identify who does not need any further evaluation. So those would identify patients who would not be eligible for clinical trials. An increase in FIB-4 tells you who might have liver disease, but it only has moderate sensitivity, and those are the patients that probably need to go on for further testing. I think the upper thresholds are better to detect advanced fibrosis F3 to F4, and they don't work so well for F2 to F4, but that's not the way they were developed, and that's not what was how those scores were designed. All NILDAs have limitations, particularly have limited data on the use after treatments, but I don't think that the simple blood-based NILDAs that I've described are going to be sense enough to use for clinical endpoints in clinical trials. So next slide. All right, and next slide. And that's it.
Thank you very much, Dr. Sterling. That's great, a review for us. Our next speaker is Dr. Keyur Patel, who's the professor of medicine at the University of Toronto, staff hepatologist at the UHN Division of Gastroenterology. He received his medical degree from the University of Southampton, United Kingdom, completed his gastroenterology and hepatology training in Western Australia and his postdoctoral clinical and translational research fellowships in viral hepatitis at Scripps Clinic and Research Foundation in San Diego and the Duke Clinical Research Institute in North Carolina. His research interests include early phase clinical therapeutic development, antifibrotic therapy, and non-invasive biomarkers of fibrosis progression. And he's been quite active in the biomarker space, especially with ELF. So we look forward to hearing his overview of the ELF test. Thank you. Dr. Patel?
Great. Thank you, Sham, and the meeting organizers for inviting me to this very impressive sessions we've had so far on during this workshop. So next slide, please. So my objectives really are to talk about the ELF components just very briefly, and then look at the context of use, which we've heard a lot about over the last couple of days, particularly diagnostic utility for either significant or advanced fibrosis, disease monitoring for progression, treatment response in NASH clinical trials, and towards the end, we have, I'll show you just one or two slides on PRO-C3, and along the way, we have some data along with ELF on FibroTest. Next slide. So, okay, so we heard from Dr. Rocky's talk that fibrogenesis is a dynamic process with balance between extracellular matrix synthesis and degradation. There are several potential direct and complex markers derived from myofibroblasts and matrix remodeling. And one thing to remember is that these markers were selected around 20 years ago for Hep C to determine who is suitable for interferon-based therapy, and before or without doing a biopsy. And so we looked at binary differentiation across a spectrum of fibrosis stages, and not to reflect the dynamic process of fibrogenesis or fibrolysis. And here we can see the ELF panel includes hyaluronic acid and P3MP as markers of matrix synthesis, and TIMP1 as a marker of reduced degradation. And the derived algorithm I've shown here is based on specific manufacturer immunoassays for the mid-volume platforms. And there are slight modifications to the algorithm for the high-volume platforms, and there are slight modifications for mid-volume platforms. And I will say, when you look back at the original cohorts for the development of ELF and the other proprietary markers at that time, FibroSpect, other potential markers were included in the initial panel to see which ones actually stood out. And for ELF, for example, include the basement proteins such as laminin, collagen 2,4 and 2 and 4, and MMP2. And for FibroSpect, for example, we included all these markers, TIMP1, P3MP-HA, along with alpha-2 microglobulin and type 4 collagens, and a selected marker at the end of the day to move forward was, were for ELF were P3MP, TIMP1, and hyaluronic acid. And this is a population which was predominantly hepatitis C. It was a mixed population, over 1,000 patients, but over half the patients had viral hepatitis, in particular hepatitis C. Next slide. Next slide. So, sorry, the graphics on this, this is a slightly different slide set to the one I had sent in. But anyway, so one of the things is selecting an appropriate threshold for context of use is really important. And this is a meta-analysis of 11 studies for F3/4 from the Litmus Consortium. And so, we have differing thresholds which we used as part of this meta-analysis, 3 different algorithms. So picking the right threshold is really important. We have the manufacturer's recommended thresholds, which are less than 7.7 for F01 and more than or equal to 9.8 for advanced fibrosis and greater than or equal to 11.3 for F4. And if you look at the graphic on the right, the National Institutes for Health and Care Excellence, remotely 2016, admittedly, are using an older algorithm, which has subsequently been revised, suggests that to identify patients with NAFLD with advanced fibrosis, that we should look at a threshold of 10.51. And if we look at the graph on the right, basically at a 5% community prevalence, the positive predictive value for low prevalence at this cutoff would be 0.26. And next slide. Actually, go to the previous slide. And when we look at a cutoff of 9.8, for example, shown on the red line up there with prevalence of 0.4, we would expect, a positive predictive value of 0.8, and 40% advanced fibrosis, something we may see in a tertiary care referral center, for example. The lower cutoffs, as you can see, 7.7 have high sensitivity, and as expected, higher cutoffs have higher specificity. But the important thing is, even in a tertiary center, 40% prevalence, you would 9.8 results in a positive predictive value of 0.8. Next slide. So, this slide actually shows, basically context of use in terms of justifying the manufacturer's recommended cutoffs. And you can see that, sorry, I apologize for the graphics haven't turned up on this, but essentially, this was a 497 patients from the original cohorts, which were revalidated on the new platform. We're using the updated algorithms. And as you can see, it's a mixed population, viral hepatitis in 43%, NAFLD only made up 10% of the populations. And this was used to justify the updated cutoffs for based on the update, based on the Siemens algorithm from their immunoassay platforms. And on the right, there was a subsequent linear regression for line of best fit to show ELF change 0.5 corresponded to one Ishak stage between Ishak F1 and F5. We can talk about the merits of this perhaps in the discussion. Next slide. So this is data from phase 3 Stellar, which was Selonsertib for 48 weeks, and the phase 2b simtuzumab studies. And the thing here I wanted to point out was basically there's a range of ELF scores which is variable between studies for the same histologic stage. So if you look at F3, the median ELF score is 10.03, and the median corresponding baseline ELF score for simtuzumab study was a little bit lower. And this highlights that basically not all F3 is created the same, as we've heard over the past day and a half. So, and the other thing to point out here is that if you look at FIB4, the scores of 1.36 and 1.76 and 2.56 all fall into this kind of indeterminate zone. So even patients with F3 and F4, the median scores were in the indeterminate range for this population in this phase 3 study. Next slide. And so when we look at the screening population from the Stellar cohort, and this is looking at F3, F4, high prevalence for advanced fibrosis, over 70% F3, F4, 40% F4. And looking at the manufacturer recommended thresholds of 9.8 and 11.3, yes, you have a pretty decent AUC. But if you look at the graphic on the bottom two graphs on the right, you can see that there's a large proportion of patients which are indeterminate, shown in green, or misclassified, shown in the purple. And this is a limitation of these tests, particularly when there's such heterogeneity in across marker profiles for a given histologic stage. Next slide. And if we look at Regenerate, this is a screen population from the phase 3 Regenerate OCA study. The ELF population had 1,170 patients, 43% F3, no F4s in this cohort. And they used lower cutoffs, 7.7 and 9.8. And you can see on the graphic on the right, if you look at the ELF, the gray bar chart there, you can see that 58% of patients were classified as being indeterminate by ELF in this cohort as well. Next slide. So this is presented by Dr. Rinella as a late breaker at EASL. And although I'm not going to talk about sequential use of ELF in the real world setting as for ruling in advanced fibrosis. This is looking at F2 to 3 because we, the idea of this workshop is to look at non-cirrhotic population. So this is looking at F2-3 in the Regenerate Reverse studies. And if you look at ELF with scores of 9.6 to 11, which is sort of in the F3 zone, 53 to 60% of patients had values which fell into this kind of 9.6 to 11 zone. So applying FIB4 in the indeterminate category 1.3 to 2.67, and then followed by ELF or VCTE, and you exclude other labs which indicate more advanced disease, so lower platelets, direct bilirubin more than 0.5 and albumin below 3.8. You can see that you can achieve a high specificity for diagnosing F2-3, and this is from a clinical large clinical trial cohort with a relatively high prevalence of F3, as I showed you in the previous slide. Next slide. So what about monitoring disease? Next slide. So in looking at Stellar 3 and 4 cohorts, this is this was a phase 3 study enrolling patients with fibrosis stage 3 and fibrosis stage 4 receiving selonsertib and ASK1 inhibitor for 48 weeks. 149 patients had disease progression at 48 weeks. And on the left, you can see that a greater proportion of patients with higher ELF scores had disease progression. And on the right, patients who are likely to have one-stage fibrosis improvement, either from F4 or F3, had lower ELF scores. Now, this is a baseline. Next slide. So when we look at the simtuzumab study, this is looking at fibrosis progression at week 96 for this phase 2b study. And when you look at ELF, you can see the baseline ELF of 10.43 is comparable. This is patients with F3 who are likely to progress. And this is comparable to patients who had F4 at baseline. So again, it shows you that there are subpopulations within histologic stages which may have higher scores such as ELF and who are at risk of fibrosis progression, or perhaps it was just some sampling error, and some of these patients may have had zones which are F4, and perhaps ELF is reflecting that. But there were no differences at baseline between patients with F3 who are likely to progress and F4 at baseline. However, when you rework this algorithm into predicting who is going to progress from F3 to F4, the predicted values were AUC of 0.79 with modest performance characteristics with sensitivity of 0.77 and specificity of 0.66. Change in ELF was not predictive of histologic progression from F3 to F4. And on the right, when you look at the combined SIM-cell cohorts, 171 patients who had F3 with disease progression, most of them biopsy F3 to F4. You can see that there is a separation at higher ELF scores for disease progression with high specificity, but poor sensitivity in this population. This all needs further validation, of course. Next slide. So this is looking at the data for Stellar 3. So this is patients with F3, and this is shown according to the treatment arms and biopsies at week 48. The main thing here is most patients basically after 48 weeks still had stage 3 to 4. So, around 70% of patients still had stage 3 to 4 at week 48. And you can see the corresponding changes in ELF and FibroTest, really no significant shifts. But again, with the caveat that most patients in the study at week 48 did remain at stage 3 to 4. Next slide. Next slide. So we look at assessment of treatment response. And again, I wish this graphic had been a little bit better. And here I wanted to really highlight that basically we know what the cutoffs are for moving forward fibrosis progression. We've seen these developed from the Hep C era, reworked and remodeled, and this is applies to NAFLD and each of the other markers, whether it's FibroTest or other proprietary tests as well. But we don't know what the actual cutoffs are for regression. And we heard elegant presentations yesterday from Dr. Kleiner, particularly looking at regressive septa and absence of ocular reaction, and from Dean Tai, looking at applying AI and quantitative measures for regressed septa. So we don't have true histopathologic scores for fibrosis regression. So we really need a new reference to measure regression before we can determine what meaningful changes in ELF are for fibrosis regression, as we have hopefully improved antifibrotic and NASH targets, which result in fibrosis resolution. But as I said, we know what the cutoffs are moving forward. We're relatively comfortable from a diagnostic sense, but moving backwards and regression, we still do not know what we should be measuring up against and what the actual what meaningful changes in these scoring systems are. Next slide. So this is again looking at baseline ELF and regression in advanced fibrosis, and this I put together so the data from F3 from the simtuzumab and selonsertib trials, and F4 again from the same clinical trials. And this is looking at biopsies either at week 48 for CellSim and or 96 for the simtuzumab data. And for F3, we looked at Ishak less than 3, and for cirrhosis, we looked at regression to Ishak less than 5. And basically, you can see that a greater proportion of patients with lower ELF scores, shown in the green here, had fibrosis regression for F3 and F4. Next slide. So what about non-cirrhotic NASH? This is a phase 2 study looking at selonsertib and simtuzumab over 24 weeks. And 30 to 43% of patients had improvements in fibrosis at 24 weeks, which led to the subsequent phase 3 STELLAR studies. But you can see there was no significant shifts in the ELF or FibroTest scores corresponding to, even in the bar chart on the left with the higher dose selonsertib arm, where there was 43% improvement in fibrosis stage at week 24. There was really no significant shifts in ELF scores or FibroTest to correspond with what we were seeing in terms of changes in fibrosis. Next slide. So I put together some of the data from various reported clinical trials, and this is shown according to study duration, treatment arms, fibrosis response, and the corresponding ELF change all the way to the right. And it's just kind of an overview, and you can see with broad strokes that most patients in these studies, as we know, yes, some people improve, some people progress, but overall there were no significant changes in fibrosis, and the corresponding ELF changes, not surprisingly, are modest at best, and small changes, and it's difficult to know what the directional changes are because very few studies have reported this. Next slide. And in fact, the only 2 studies which I could find reporting directional change, and if you look at the CCR25 study with fibrosis either improving yes or no, you can see the corresponding ELF change, really minor changes and not really following directional change with improvements in fibrosis. And the same with the study at the bottom as well. You can see no significant changes in the PIVOT study with directional changes with ELF. Next slide. So this is looking at pool data from the simtuzumab selonsertib NASH cirrhosis trials, and you may hear about this in the rest of the afternoon session. But essentially, 176 patients had regression of cirrhosis at week 48. Patients with liver-related clinical events over median 16 months, 71 of those patients. And in fact, cirrhosis regression was associated with the reduced risk of clinical events in this study. And when you look at baseline NITs, either ELF or some of the other simple markers such as NFS or FIB4 or VCTE liver stiffness, certainly ELF at baseline, higher ELF at baseline was associated with the risk of clinical events, but changes in ELF were not associated with risk of clinical events, unlike the case for NFS and the VCT, where higher scores at from baseline in terms of change were associated with risk of clinical events. Next slide. And so final couple of slides. I just wanted to highlight that basically ELF, as I mentioned early on, and in fact, all the other markers we have in the clinical space that's readily available, they're expected to cover several roles for a biomarker: diagnostic, prognostic, monitoring, disease progression, regression, treatment response. And they were never designed this way. We really need biomarkers to assess that dynamic assessment. So if you have a fibrogenesis marker that might be useful for disease progression, a fibrolytic marker might have a role for antifibrotic efficacy. And we look at P3MP, which is part of the components of ELF. There are related subfragments or neoepitopes, which may give you better information. And ProC3 is one of these components of P3MP, which may give you better information on formation of matrix. And there's other type 3 collagens, which such as C3M or CTX3 telepeptide of collagen 3, which may be used for fibrolysis. And again, you'll see ProC3 being put into various algorithms this is just one example in the ADAPT study, and we'll see more and more data of this for these markers. I hope ProC3, the utility in terms of context of use outside diagnostic algorithms still need to be validated, but we'll have increasing data for sure from our clinical trial space. Next slide. And so just to summarize this talk, put ELF, and this could apply to FibroTest or some of the other markers too, for the most part. So looking at a diagnostic marker, yes, F3, 4, yes, there is a current clinical utility. I didn't talk about a sequential use in primary care settings, etc., in the real world. But there are validated thresholds for NAFLD. There are variable optimal thresholds depending on the population you study. But if you follow the manufacturers' algorithms, and particularly their cutoffs, we should have some homogeneity in this regard. For F2 versus F3, no. F2 and 3 versus F4, no right now. For disease monitoring, F2 to F3, no current utility and no validated thresholds. F3 to F4, I showed you some data saying yes, possibly with modest performance characteristics. The sensitivity and specificity below 0.8. For treatment response, either measuring progression or regression, not right now. And prognostic use, well, this is ELF has a approved indication for this. There's limited validation, I'd say, outside the clinical trial data I showed you. And you can categorize patients into low, high, medium and high risk categories for disease progression or liver-related events, but does require further validation. So next slide. So with that, I thank you for your attention.
Thanks, Kayur. Thanks, that was great.
Thank you. So welcome, everyone. I just wanted to remind you that the goal of the workshop is to assist FDA in identifying current knowledge gaps for using non-invasive tests as diagnostic biomarkers and reasonably likely surrogates, and provide a framework for the additional data needed to fill these gaps. The primary focus of the workshop is non-cirrhotic NASH/MASH populations with advanced, that is stage 2 or stage 3 liver fibrosis. We're especially interested to hear from the circulating biomarkers experts how these biomarkers may be used as prognostic enrichment, diagnostic, and response biomarkers. And again, welcome.
Thanks very much. So what I'll do is I'll introduce each of the panel members, and maybe they can give us a few minutes perspective on their role and what they think of on the circulating biomarkers. So I'll start with Dr. In-Suk Kim.
Hello, this is In-Suk Kim, the Master Scientist in the Office of Clinical Pharmacology at FDA, and we're supporting the drug development and evaluation of the for NASH treatment. So a few things I'd like to make a comment. So, based on the presentation, there are not like this circulating biomarkers are ready for prime time, but I do, want to emphasize and encourage that we continue investing on this circulating biomarkers, although those may not be ready for prime time at this point, because in the clinical trial as well as a clinical practice, we need something easily measurable and that can be used for disease progression as well as for dosing. I'm in the clinical pharmacology now. We are very keen into how to select the dose for this type of disease, especially very heterogeneous as well as a progressive. So we need to know at what point patients progress to the cirrhosis or even the more advanced liver disease. So the dose, at the initial dose, considered appropriate at the beginning of the disease may not be appropriate anymore, or may need to be adjusted, as the disease progresses. Currently, clinical pharmacology do not have much tools to use to assess the severity of the liver disease, although we all know that liver disease may affect drug elimination pathways significantly and then change the risk benefit as the disease progresses. So I do think, we need to continue investing on this circulating biomarkers. And also, when we do continue work on this biomarker, we need to be very mindful of the importance of bioanalytical assay validation. So as we saw in our neighbor, the chronic kidney disease area, Cockcroft-Gault equation has been used for GFR estimation, and it has been used for drug labeling and for dosage adjustment. And later on, there was a big effort to make sure the assays were validated properly, and then turned out to be it's overestimating the creatinine, serum creatinine. So the Cockcroft-Gault equation is not being used anymore for the drug labeling, because the dosage adjustments based on that eGFR may not be appropriate anymore. So, when we continue investing and developing the biomarker for liver disease severity, more like a diagnosis, we need to be mindful of the importance of the bioanalytical assay method, the validity of it. So, another thing I wanted to emphasize is really also biomarkers, especially circulating biomarkers can vary and then fluctuate, as we all know. And then also we need to pay attention to what are the factors that contribute to the variability of the circulating biomarkers. Assay itself can be one factor that really contribute to biomarker fluctuation, but there could be other factors like demography and BMI or age, as were discussed by the speakers. So those are also a very important factor. And clinical meaningful changes, we all know that, we are not there yet, but then, by continuing the studying this circulating biomarkers, it's in the context of the clinical outcome study, maybe we can get there at one time in the future. So we need to continue working on this. And also briefly, like I mentioned yesterday by a speaker, that when we are evaluating any biomarkers, dose dependency in terms of the treatment response, assessment of the treatment response, if there is a dose dependent change, that may give us a little more confidence in the change we see in any biomarker, including circulating biomarkers, maybe really due to a treatment effect, not due to some variability or noise. That's my comment. That's it. Thank you.
Thank you, Dr. Kim. Next, I'll have Dr. Naeem Alkhouri give an introduction and give us some perspective.
Thank you so much, Tuaman, for the FDA for inviting me. So Naeem Alkhouri, I'm the Chief Medical Officer and the Director of the Steatotic Liver Program at Arizona Liver Health. We are a network of research sites with a focus on MASH drug development. And actually, I want to highlight several of the issues that we face on a daily basis due to the current approval pathways. in our practice. So every day in our program, we see patients that screen for MASH trials where the biopsy reading will come back as F3, bridging fibrosis. They have an NAFLD activity score NAS of 4, but then there's no ballooning on the biopsy, and they fail for the trial. This is a very unfortunate scenario. These patients clearly have the aggressive form of the disease. They have F3 fibrosis. They are on their way to cirrhosis, and denying them participation in trials will limit the ability to generalize the findings from the current drug development programs to the real-world MASH population. A second point is that the use of NASH resolution as an endpoint is problematic. It has never been shown to predict any outcomes, and it doesn't accurately reflect improvement in disease activity. And let me give you an example. A patient can go from a NAS of 8 at the beginning of the trial to a NAFLD activity score of 2 at the end, but still have 1 point on ballooning on the biopsy, and this patient will not qualify as a responder, despite clearly improving disease activity from 8 to 2, which is very significant. On the other hand, another patient can go from a NAS of 4 to a NAS of 3 and just lose 1 point on ballooning, and now they have 0 for ballooning, and this patient will qualify as a responder. The third point is that there's really poor agreement on ballooning, which we emphasize on tremendously to define NASH and NASH resolution. And there's poor agreement among expert pathologists. A landmark paper that was mentioned previously by Brent et al. Demonstrated this clearly, where one expert pathologist will quantify ballooning as having 0 to 5 ballooned hepatocytes in a specific slide, and then another expert pathologist will count more than 50 ballooned hepatocytes in the exact same slide. Finally, and most importantly, I think I want to emphasize this point, all we are asking for as experts in drug development for MASH is the ability for non-invasive tests, NITs, to lead to conditional approval and not full approval at this point. We are not asking to replace biopsy for conditional approval yet. We are just asking to provide an alternative pathway based on NITs. I think there's consensus in the field that having several NITs improve at the end of the trial should have the same likelihood of NASH resolution on histology as a reasonably likely surrogate endpoint. And as an example, a patient that improves their liver fat fraction on MRI PDFF by 30% or more, plus ALT by 17 units or more, plus improvement in liver fibrosis, whether it's measured by vibration controlled transient elastography by 5 kilopascal units or 30%, or potentially a reduction in ELF by 0.5, or maybe using a composite score such as the MAST. There's consensus that this represents improvement in disease activity and could be a reasonably likely surrogate endpoint. I do believe that the same burden of proof that was applied to NASH resolution as a reasonably likely surrogate endpoint should be applied to combination NITs as an alternative, again, for conditional approval. And finally, I just want to thank the FDA for giving us a pathway for drug approval over a decade ago when limited data existed and we had to rely on histology. Thank you.
Thanks, Dr. Alkhouri. Next, I'll have Matthew Gee introduce himself.
Yes, hi. I'm Matt Gee, Director of Regulatory Affairs with Siemens Healthineers, and I've been supporting the ELF test for more than 10 years, and I work with Dr. Cappuccino's team to achieve de novo marketing authorization of the ELF test in 2021. First, I'd like to say thanks to FDA for organizing this workshop, and also I think that Dr. Patel did a nice job summarizing the utility of ELF across multiple contexts of use. So for my time, I just want to offer some additional context on how ELF can be used as a biomarker in clinical trials. In my opinion, I think the strongest evidence of ELF's clinical utility so far is its prognostic performance, and that kind of explains why we chose that pathway with FDA when we submitted our de novo submission. It was for prognosis in patients with advanced fibrosis due to NASH. But additionally, the prognostic utility of ELF is supported by AASLD's recommendation of ELF for risk stratification. There's also more than 10 reports validating the prognostic use of ELF in populations representative of MASLD. And we've also observed in multiple clinical trial data sets that individuals with ELF less than 9 are very unlikely to have liver-related outcomes in a time frame that's typical of a clinical trial. And also notably, a report from the UK showed that an ELF score above 13 predicts 40% mortality within 6 months. So I think that's pretty important for clinical trials, because it suggests that ELF can potentially enrich these trials with subjects that are more likely to have outcomes, while excluding subjects unlikely to benefit from treatment. In terms of diagnosis, I fully acknowledge that there's been a wide variety of cutoffs published in literature. With regards to the 7.7 cutoff, although it's referenced in the AASLD guidance, there's very limited evidence to suggest that the 7.7 cutoff is meaningful, with several studies demonstrating that it has suboptimal specificity. And this is really illustrated by the fact that 7.7 is the median ELF score seen in an apparently healthy population. We've seen that with US, European, and Asian populations. So we've seen Healthineers is really no longer recommending use of the 7.7 cutoff. In terms of detection of advanced fibrosis and cirrhosis, the 9.8 and 11.3 cutoffs are recommended in the AASLD guidance for detection of advanced fibrosis and rule-in of cirrhosis, respectively. Just point of interest, the ELF test was granted breakthrough device designation back this June based on, in part, a reasonable expectation that these two cutoffs could potentially could more effectively identify advanced fibrosis and cirrhosis. And yes, I agree that the 10.51 cutoff referenced in the NICE guideline is recommended for detecting advanced fibrosis. It's important to note that this is based on data from the study by Nobili et al., who used a pre-commercial version of the ELF algorithm, which is aligned to the Scheuer staging system. But our commercial ELF algorithm is aligned to Ishak. And interestingly, and as presented at the most recent Paris-NASH meeting, our team derived and validated a transform equation to convert the Scheuer aligned ELF score to Ishak aligned ELF scores. And after applying this transform to the 10.5 cutoff listed in the NICE guideline, remarkably, the score is transformed to 9.80. So there's very consistent evidence supporting the use of the 9.8 and 11.3 ELF cutoffs for clinical trial use. In terms of significant fibrosis, I agree, there's no clear consensus at this point regarding an ELF cutoff for this context of use, but there's emerging evidence that a cutoff at 9 could be useful, and that would need to be demonstrated with more data sets. Regarding treatment response, validation of the ELF test for this context of use is very much a work in progress, but will require correlation of changes in ELF with changes in clinical outcomes. To date, most results have focused on mean change in ELF to compare clinical trial arms rather than validating the biomarker itself. Also, mean ELF changes have been highly variable across studies, as presented by Dr. Patel, suggesting that the rate of ELF change might be influenced by a variety of factors, such as mean ELF at baseline, drug mechanism of action, study duration, and in my opinion, drug effectiveness. And rather than looking at mean ELF changes, I would argue that it's probably more helpful to look at patient-level changes in ELF as a potential surrogate for disease improvement, either by looking at a delta, for example, decreased by 0.5 units or more, or by crossing an established threshold, like 9.8. Notably, the Harmony study of efruxifermin in their 50 milligram arm, ELF had a mean decrease of 0.7 units at 24 weeks, very, very short time. And 75% of subjects had their ELF score decreased to below 9.8 by that time point. Similarly, there's the Alpine 4 trial of aldafermin, where that study actually used ELF as a primary endpoint, specifically a decrease of 0.5 units or more. And statistically, more patients in the 3 milligram arm versus placebo met this endpoint. So that's kind of interesting by looking at the individual patient level. Additionally, in internal analyses, we've seen a halving of liver-related events in patients with a 0.5 unit reduction in ELF score from baseline, but with caveats that this was not a statistically significant analysis, and it was only applicable to patients with an ELF score greater than or equal to 9.8 at baseline. So the patients below 9.8 may not be relevant for looking at changes. So just in summary, I think ELF may prove useful to evaluate treatment response, but this is going to have to be addressed by the ongoing phase 3 clinical trials. Okay, thank you.
Thanks very much, Matt. That's a great summary. And next would be Anup Amatya, Dr. Anup Amatya.
Thanks. Good afternoon. I'm Anup Amatya. I'm a lead mathematical statistician in Division of Biometrics 5 at FDA. My team supports medical divisions that oversee oncology drug development. So it's kind of in a little different disease area. But in oncology, we face many of the same challenges that we're discussing today regarding surrogate endpoint validation. You know, we have had several candidate endpoints and biomarkers, actually much cleaner than the one we're discussing here, that we have considered as a potential candidate for a surrogate reasonably likely to predict clinical benefit. And several studies had also shown high correlation between these candidate endpoints and the clinical benefit endpoint. But there hasn't been a sufficient evidence to validate them. Some of those endpoints, which were initially considered as a surrogate endpoint, actually now are used as a clinical benefit endpoint on itself, like progression-free survival. Now, from a regulatory perspective, I think the important question that needs to be answered is what magnitude of treatment effect on these biomarkers would predict a meaningful improvement in definitive clinical endpoints. Would the benefit risk assessment based on these biomarkers be the same had we waited for a trial to meet the definitive endpoint? That's the key question. You know, and it's pretty much known that the correlation a surrogate makes, and so having the correlation between the biomarker and the clinical benefit endpoint, which we call individual level surrogacy, that alone is not sufficient. We need a trial level correlation, some way of demonstrating it to establish that biomarker as a reasonable likely surrogate endpoint. Otherwise, you have to rely on epidemiological mechanistic justification. And while doing so, I think the biggest challenge we face is the lack of clinical trials where these biomarkers have been measured and the clinical endpoint has been measured in the same trial. And you know, another challenge we face is that sometimes different trials use different cutoff values for a biomarker, and endpoint definition are also different across the trials. So going forward, you know, harmonizing how biomarkers are measured and how clinical endpoints are defined is going to be very important if we want to validate these endpoints. Another very important point is that once these endpoints have been validated with the clinical trial data, now another challenge would be extrapolating that surrogacy to a new class of drug or a new subset of population. So because of these reasons, even in oncology with the real clean biomarkers like PCR, you know, the pathological complete response rate, which is just dichotomous, yes or no, we have had a difficulty. While I do understand the urgency of this some type of surrogate endpoint, but at the same time, I do see a lot of challenges in establishing these NITs as surrogate endpoint likely to predict clinical benefit. With that, I'll stop and thank you for letting me participate in this panel.
Thank you very much, Dr. Amatya. So I think now we'll open up the panel for questions. I think Dr. Cappuccino has a question that she might want to have the panel address.
Let me come off of mute. So ELF test is indicated as a prognostic marker in conjunction with other laboratory findings and clinical assessment in patients with advanced fibrosis, F3 or F4, due to non-alcoholic NASH or due to NASH, to assess the likelihood of progression to cirrhosis and liver-related clinical events. So that is, as you guys know, the authorized indication for the ELF test. Can reversal of ELF scores also provide information on the reversal of disease? So this was partially discussed. There seem to be some different thoughts on this.
Yeah, I mean, I think ELF is considered a dynamic, panel. It has 3 biomarkers in it. Definitely has more potential than other, scores that we use, such as NAFL fibrosis score, FIB4, to actually predict response to treatment, monitor disease progression and disease regression. I think one of the points that were made is that the baseline ELF, regardless of the stage on biopsy, has its own prognostic value also, which, in a way, it highlights the limitations with biopsy. So 2 patients can be read as F3, but the one with higher ELF is more likely to end up with cirrhosis on a repeat biopsy in the context of a clinical trial. This has been an issue, and we realized that when we do actually non-cirrhotic NASH trials, we include F3 patients, that about 15 to 20% of them, in fact, they have NASH cirrhosis. We see it on the NITs, you see it on the FIB4. So I think, ELF by itself has its own prognostic value, as you said, but also it can reflect dynamic changes.
So I think there are better markers for assessing dynamic changes. I think, as I showed you in the first few slides, yes, it's better than the simple markers and the indirect markers for sure. But I think one of the things we have to remember is ELF, for me, and Matt can correct me if I'm wrong, is it reflects kind of disease activity and not kind of the the fibrogenic burden as such, or the amount of collagen. And there's a wide, even F3s, F4s, they all have a wide variety of, wide range of the actual amount of collagen deposits and tissue. We don't have any markers which reflect that. ELF, like everything else, reflects the activity. And yes, in an F3 or an F4 population, F2, there are subpopulations who have less of that pro-fibrogenic activity, but it's yet to be shown that they have fibrolytic activity, or and how we follow these patients, and what a meaningful change of 0.5, which is derived, after all, from a line of best fit. We know the deposition of collagen is not linear from, as we progress through the stages. And how can we expect regression to be going along the same path? We showed, yesterday we discussed that patients may still have nodules, but regress septa. We need better ways of measuring that and quantifying it, and then looking at these quantitative variables. One of the biggest problems we face is we've always tried for 20 plus years to have quantitative assays, various tests, and trying to measure up against semi-quantitative categories of fibrosis. So I think we can do better. And for me, changes, I still don't know what change is significant in terms of reflecting regression, whether it's regression of septa, absent ductal reaction, or other favorable changes we see in histologically, for sure.
Matt, I see you have your hand up next. You're on mute.
Sorry about that. Yeah, I think there's the data so far, it definitely doesn't present a compelling case for use of ELF as a treatment response marker. So I think the problem is the challenge that I've seen is that, well, ELF, it's logarithmic. So it takes a lot more effort. There's a lot more resistance to change ELF. So other markers, yes, you might see a quicker response in a shorter time, but how long lasting that is, that's the question. We've seen other markers that have a dramatic change in a short period of time, but then trend back towards their baseline level after a period of time. Whereas what I expect, obviously it needs to be borne out by the science, is that ELF, if you change ELF over time, it'll reflect a greater change in the course of the disease. As I was mentioning in my quick summary, when we've looked at some data, I think the challenge too is that a lot of the times the analyses are looking at the means, right? So if you're looking at mean, you're bearing a lot. It kind of gets all mixed and jumbled in the noise. If you look at individual patients, what I recommend is looking at patients above or equal to 9.8 at baseline, because the patients below 9.8, the ones that, especially those below 9, they're not having events at all. So changing an ELF for those patients is kind of irrelevant. The patients that I would say focus on are the ones above 9.8, and again, not statistically significant, and we need more data to support this, but in some analyses we've done, having a results, having liver-related events for the patients that have an ELF decrease of 0.5 in the greater than or equal to 9.8 at baseline. So there's a lot more to be done. I'm really encouraged by some of the new, more efficacious antifibrotics that are under study right now. And I think we're going to see, with that data, if you see an efficacious drug, then you really have something to really test the performance of ELF against. So I think we're limited based on the existing data, but hopefully in the future we'll be able to address this question.
Yes, that's true. And I think we heard from yesterday is that Dr. Goodman said, if the therapy is good enough, pretty much you're going to see a response with all of these markers, right? So I think it'll be interesting to see how as the therapeutic landscape evolves. Dr. Alkhouri, I think you had your hand up next.
Yeah, I just want to take us maybe a step back, and I acknowledge that no circulating biomarker is ready today to be used like hemoglobin A1C. We're not there yet, but I think when we look at what we are trying to do with liver biopsy, I mean, what are we looking at? We're looking at improvement in activity, right? Inflammation ballooning, steatosis, and fibrosis. And I think with combination non-invasive tests that we can actually look at these variables in potentially a more accurate way than a liver biopsy. So what I was trying to make the point is that, if you have 3 biomarkers, one that assess steatosis accurately, like MRI-PDFF, another biomarker for disease activity as simple as ALT, and then you have a fibrosis biomarker. Maybe we don't understand the threshold yet, but at least it's not worsening to avoid a scenario when a patient is losing steatosis and progressing in fibrosis, and the steatotic biomarker is misleading you. I think if you have a combination of 3 NITs heading in the right direction, that should have the same value as NASH resolution on a liver biopsy. I think this is where we're at today. I don't think MRI-PDFF alone is ready. I don't think ALT alone is ready, but this is what happens in the real world. This is what will happen after drug approval. And based on the level of evidence we have for NASH resolution today, I think there's enough evidence to show that combination NITs should have probably the most significance in terms of, providing an alternative conditional approval pathway. So I agree, ELF by itself probably is not ready. And I feel like there is a lot of back and forth in terms of, are we ready to just design trials based on biomarkers and we don't need outcomes anymore versus conditional approval that's still linked to outcomes?
We'll take one more comment on this question because I think we have another couple of questions we wanted to address. So Dr. Patel, one more.
Yeah, just a minor point, which I didn't make during the talk, was, if you look at the components, hyaluronic acids like relative always turns up at our at the parties. We've been trying to get away from HA just because of its very non-specific nature. I'd say when you look at TIMP1, P3MP, they reflect activity at different stages of fibrosis, and yet we have components which are important towards the later stage of fibrosis and some which are important at the earlier stages. And when you put them all together, I think that's one of the limitations we have when you look at individual components. I mean, postprandially, HA may go up, and there's lots of variability as well. So, again, in the real world, we still are awaiting utility of these of these data.
Anoop, did you just have one quick comment before we move on to the next question?
Yeah, it's just, regarding the conditional approvals thing, one thing I want to point out is, once you have that conditional approval, that tend to, interfere with the future data that might be needed to validate that biomarker.
Yes, that's true.
So we have focused on FIB4 and ELF tests. Are there other circulating biomarkers that have robust data to support use as a diagnostic and treatment response biomarkers? We heard about PC3.
Yeah, I'd also love to hear, because we heard from Dr. El-Khoury about ballooning, and we've heard that sort of consistently through yesterday and today about how challenging ballooning is on biopsy. Along with the other potential other biomarkers that you guys are going to talk about, is there anything that you've seen or is in development that could sort of pick up more around the ballooning question? So I'd add that to as an adjunct to the question that Dr. Campesino read.
I mean, of course, everything we discussed was to predict fibrosis stage, but there are biomarkers that are being developed to predict at-risk MASH, which means that you have a MASLD activity score 4 or more and F2 or higher, and that includes biomarkers like NIS4 and NIS2. So that includes activity in a way and reflects ballooning. There's also some biomarkers using metabolomics like MASF. So this is an area of active research. And I think, we have good data in terms of baseline prediction of at-risk MASH. I think what we lack is still the dynamic changes and response to treatment data. But that data is being generated as part of the ongoing clinical trials.
Dr. Sterling.
Yeah. I think, what we really didn't hear about yet, and I'm hoping it'll be discussed in the last session, are the newer scores like the Agile scores, which sort of, again, combine these things. But I think, we're here talking about diagnosing and treatment. So I do think that, all these tests that we're talking about, there's never going to be a one size fits all. We have, if you think about the patient journey, which is really, I think we should be patient centric about how we think about how these are going to be used, because it's the patients who are going to end up being the ones who undergo these tests and potentially undergo the therapies. There are, different ways that these tests can be used. And so things like the simple non-invasive tests, like I talked about, like the FIB4, are very good for the general populations to identify who doesn't have liver disease. So, and that's what the AASLD guidelines reflect. So if your FIB4 is less than 1.3, or if you have that really low NAFLD fibrosis score, those are patients that are very unlikely to have anything. And those are patients, I think, that don't necessarily need to go through all the things that we've been talking about. Those with a score of greater than 1.3 are those who might have a liver problem. And those are the ones who are going to then undergo these secondary tests, whether it's elastography by some radiographic method, or ELF, or one of these other tests that might help predict who has more advanced disease. And those are the tests, therefore, that might also predict outcomes of the patients who we really need to think about. And then they might go to a third level of testing, whether it's a more sophisticated test or a combination of things, or for monitoring therapy. The advantages of something like FIB4 and even VCTE or ELF is that they're point of care testing. We don't need to do anything else. FIB4 is free, and most of us, at least in the hepatology world, have the FibroScan machines in our clinic, although there are other modes of elastography that are done by the radiologist, such as the shear wave. So I think we need to think about that. And then lastly, how do we monitor for therapy? And I don't think the simple tests are there yet, as we've talked about. And it's not really clear whether these combinations of methods that can get at ballooning and inflammation and fibrosis and all the things in steatosis that we look at for treatment outcomes, they're never going to be answered by one test, because one test doesn't do everything. So I do agree with the other speakers, is that it's going to have to be some kind of combination. We just need to figure out what that combination is going to be, what a meaningful change is going to be that's going to benefit the patient.
So I'm hearing that you have a high level of confidence for the circulating biomarkers like FIB4 and others to rule out a patient who needs intervention, and then in combination rule in the ones who do need intervention, right? So we're enriching a patient population for a clinical trial so that you don't end up, having to lose that patient in a screening and not be able to enroll that patient in a clinical trial.
Well, I mean, the positive predictive value, again, depending on the prevalence in the cohort that you're looking at, is not great for a lot of these tests. And from what I saw from CARE's presentation on many of his slides, it looked like FIB4, which is free, performed just as well as ELF, which at least last time I checked was about $280. So I think these simple tests are very good in seeing who you don't have to worry about, and then identifying those who need to go on to further testing. Now, whether they need an intervention is sort of, again, I think sort of the next level, because as was mentioned, by one of the other, panelists, I've had patients that I could swear had NASH. They have elevated ALT, they look like NASH, they smell like NASH. You do a liver biopsy, they have bridging fibrosis, they have inflammation, they have steatosis, but yet there's no ballooning. And I say, well, the pathologist obviously was, maybe didn't get a good night's sleep. I've personally gone over those biopsies, cell by cell, and there really is no ballooning. And those patients are excluded from trials. And I think that's really a problem, as was mentioned, because, those are patients that clearly they're developing disease. They've got, bridging, and they don't drink, and they don't have viral hepatitis or any other, liver disease, and they're all excluded. So I think we need to figure out how to include them and be more inclusive, because ultimately no one's going to get a liver biopsy when these drugs get approved. They're going to get some non-invasive test, and they're going to go, okay, I think I can help you. So that's how they're going to be used in practice. And if they're not included in clinical trials, we'll never know what it means for those patients.
Naeem?
I just want to emphasize the point that you made, Tram, about, combination NITs increasing the positive predictive values. So we have very good data from the Gilead program showing that, if you have elevated FIB4 plus elevated ELF, or elevated FIB4 plus elevated liver stiffness measurement, that your positive predictive value in a, of course, high prevalence population in the context of a clinical trial that was focused on F3 and F4, that your positive predictive value is more than 95%. So I agree with you that in a hepatology clinic, we need to be using probably combination of 2 NITs to increase our positive predictive value and not expose patients to unnecessary, aggressive pharmacologic treatment. And you're absolutely right about the high negative predictive value. And maybe we don't need more than one test to rule out significant disease. But this has been shown over and over. And I think, in terms of baseline determining disease severity, we have enough confidence now that if you have 2 NITs pointing in the right direction, that this patient has significant disease.
Any other comments on this question? Great, we'll move to the next question.
What are the patient populations in which NITs have already been evaluated? Are the results obtained from NITs so far applicable to the general population with other comorbidities? Can age, sex, BMI, or the presence of comorbidities influence the results of these NITs? For example, FIB4 can be affected by age, pulmonary fibrosis, or cardiac disease, which may affect interpretation of liver stiffness, etc.
Dr. Sterling. You had a very long list on that slide.
Yeah,
tell me
so.
on that slide.
Yeah. So I would say it's on that slide. I mean, I think that with all these tests, you need to know what you're going to do with the result. I'll often get called by somebody who did some kind of non-invasive test and they get a value that they weren't expecting. And then they call me and they want me to figure out what I'm supposed to do with it. And when I look at the clinical picture, for example, a patient with really severe right heart failure who has elevated liver enzymes, and we know that they probably, they've got all the signs of hepatic congestion, yet their biomarkers are elevated. And someone asks me what I'm supposed to do with the result, and my response is, I don't know, you ordered it, you must have had some idea. So I do think that there are clinical conditions that must be taken into context when you order these. As far as the populations, and this is going to be in, I think it'll be table 15 or table 11 of the AASLD guidelines. There's a whole list that we identified where we just don't know how these tests perform. So we know pretty much how they perform in referral practices. There's increasing data how some of these might perform in, for example, diabetes clinics where they might not perform as well as we expected them in some of the clinical trials and in the cohorts where they're done in tertiary referral centers. So it's a little less clear how these perform out in the general population where the prevalence of advanced fibrosis is going to be pretty low, maybe on the order of just a few percent. And that really, and again, those patients aren't going to get biopsied. So it's going to be hard to know, what to measure against in that population. They're increasingly being looked at in the HIV population. And so there is increasing data in that group, but in minorities, in these other sort of populations where they've never been studied, we just don't know. So we can extrapolate, but I do think there's enough differences that we might have to redefine what some of the thresholds might be. Certainly with FIB4, there's already sort of, modified ages. Anything with age in it is going to be modified by age and how old the patients are. Just like, MELD, I think we're to MELD 3.0. I think ultimately we're going to have a FIB4 3.0 or something that's going to be, modified by this. And I've already seen some of the, people trying to do that. So
taking the FIB4 with all its complexities out to the general population might require a little bit more thought when we're talking about a huge population of all the patients who could be at risk for MASH.
I think something like the FIB4 still works really well on the low end, regardless of the population. I think where it's going to require a little bit of maybe modifications is going to be maybe on the upper ends, particularly in the really low advanced fibrosis, prevalence disease. But again, if you can't biopsy everybody, you can't do elastography on everybody, you can't order an ELF on everybody or whatever other proprietary test that you want. But something like FIB4 helps screen people out so you can, focus your efforts on the people who might actually benefit.
Naeem?
Yeah, I completely agree with Dr. Sterling, and I cannot wait to start using that table he showed to educate providers about the limitations of all these tests. And one thing we do in our clinics routinely, we face on a daily basis is, for example, FibroScan is affected by high BMI. And sometimes we have patients that are 25-year-old, no diabetes, no other comorbidities. You do liver stiffness and it comes back at 15 kPa, which is consistent with advanced disease. And this is when, combining the serologic markers, and you can do something like the Agile 3+ or Agile 4, which basically what they do is, in my mind, they combine a FIB4 with the FibroScan measurement, and they have a couple more variables, but that will increase your positive predictive value in a specialty clinic, or you can do a completely different test like ELF and look at the combination of ELF and liver stiffness on transient elastography. And as Dr. Sterling said, I mean, your positive predictive value is always going to be affected when you have lower prevalence. So, some of the new calculators that we are using, actually, you can adjust the prevalence of the disease state you're trying to diagnose in the population before you get the score and before you get the interpretation. So you can actually, if you're looking at, let's say, significant fibrosis in the general population, you can adjust it to 6 to 10%. If you're looking at a hepatology clinic, 25 to 30%. And this is basically incorporating pretest probability with the interpretation of the test. And we use things like a Fagan nomogram to do this as well. So, this is how we interpret these tests in the context of clinical trials in practice. And when we have also medications approved, we will utilize the same concepts to monitor response.
I might just push and ask Matt and Kayer about ELF and its limitations. So we saw the list for FIB4, and Kayer, you touched a little bit on HA, but are there other limitations in the practical use of ELF with patient populations as well? Maybe Matt first, and then Kayer.
So from an analytical limitation, we do recognize that biotin is an interferent. So, that would need to be taken into consideration. So if patients are taking high dose biotin supplements, scheduling would need to be done to ensure that biotin is clear the patient's system. In terms of drug related, in terms of the clinical condition, I mean, there are other conditions that have fibrosis. We've seen, trying to think, I mean, cystic fibrosis could be a contraindication, but anything that causes similar elevations in HAP3 and PNTEMP1 would cause an elevation in ELF. So, I mean, ELF, when you look at the prognostic performance, you're not predicting, it's not a 1-for-1. So if you're above 11.3, you're not going to catch everyone who's going to progress to an outcome. If you're below 9.8, it's not a guarantee that you're never going to have an outcome. But some of the data we've seen, if you can maintain it yourself below 9.8 over time, then it's unlikely that individual would progress.
Here. You're on mute.
Sorry, so hyaluronic acid, when we looked at for Hep C as a single marker, as for change in fibrosis as part of panels years ago for Hep C, certainly a postprandial state affected hyaluronic acid levels. So, we did recommend fasting state certainly for that panel. And as Dr. Sterling showed you on post-gastrectomy, et cetera, patients who have perhaps Roux-en-Y's, et cetera, we don't know exactly, may have different HA levels. But just to echo Dr. Al-Khoury's point, when we looked at the guidelines, which Dr. Sterling mentioned, remember, for most of these tests, the likelihood ratios fell between, were modest, basically, and likelihood ratios based on the nomograms you're seeing from Dr. Newsom and Naim just mentioned, they change your pre-test probability. So, in the best case scenario, if you have a likelihood ratio of 10, increases your pre-test probability up by 45%. Most of the markers didn't really come anywhere near that, basically. And this is looking at, a rigid kind of systematic review for all the markers in Hep C, B, et cetera. They were modest at best. And when you look at the sensitivity and specificity, that's what this is based on, basically. The prevalences affect your positive, negative predictive values, and we can go back and forth and argue about that. You need higher cutoffs for low prevalence states to rule in disease, et cetera. But essentially, all these tests, their sensitivities and specificities, fall below the benchmark of 0.8, essentially for a diagnostic biomarker. Yes, if you exclude a third of patients with simple tests and, who have fallen into the indeterminate zone and apply secondary tests, we get there sort of. But I just wanted to make that point. You have to have a good pre-test probability in a patient, whether it's for a clinical trial, whether it's in the real world, and then apply these tests in accordance and build up, as I like to say, like a story in your mind that this patient has a higher likelihood or not a high likelihood of having significant disease where you may consider an intervention. So sorry, long about way of answering the thing. But HA does have issues. P3MP and the other components of ALF, I'm not so sure, as Matt said. I think they're okay in terms of diet and postprandial use.
So we're at the top of the hour. We have 5 minutes left. I'll see if Dr. Sterling has comment, and then maybe we'll get some final comments from everyone on your thoughts after the discussion.
I forgot to lower my hand.
Oh, it was legacy. Okay.
Yeah,
Yeah.
it's getting tired.
Any other final comments from the group as we sort of wrap up? I think it's been a really great discussion. Dr. Cappuccino, do you have any thoughts or comments?
No, I've enjoyed the discussion.
Yeah, so I think what we've gotten here is that we're in a pretty good space with the circulating biomarkers in terms of maybe ruling out the patients that might need, ruling out the lowest risk patients. Then once we get to ruling in the higher risk patients, it gets a little trickier and might need some combination, but I think that's where we are. I think the trickiest part that we've heard about throughout the course of the last day and a half is really the magnitude of effect of treatment response. And we are really, and thanks to Matt and others who are saying that we're generating that data is being generated now, and we hope to see that as quickly as possible for the magnitude of response. I would just sort of say at the end of the day for this session, at the end of the day, the gold standard really is clinical outcomes. And so if we can get to something that can predict clinical outcomes, I think that's really the goal, right? And I think we are still working on that. I think it's still a work in progress because, I think we are getting there with the clinical trials that are planned, but I think we still have a bit of a ways to go. So any other comments? I think we are scheduled to finish in 3 minutes. So I think we'll finish a couple minutes early, and then we'll come back for session 4, which is future considerations for NITs in clinical trials and clinical practice. So it's like the hottest session for the entire 2 days. So I'm sure everyone will come back for that session at 2:25 Eastern time. So we'll see everyone back then, I think, unless anyone else has any other questions or comments. Okay. Thank you, everybody. It's been a wonderful panel.
Good afternoon. I'm Frank Anania, the Acting Director of the Division of Hepatology and Nutrition, and we've come to our final session of today and of the entire workshop. We have 5 invited speakers today who I think will summarize and cap what we've been discussing in the last 2 days. I'd like to introduce them now, and then we'll proceed with their talks. The first speaker, Dr. Arun J. Sanyal, is Professor of Medicine, Physiology, and Molecular Pathology in the Division of Gastroenterology at Virginia Commonwealth University Medical Center in Richmond. Dr. Sanyal serves as chairman of the NIH NASH Clinical Research Network, the NIMBLE Consortium, and the Liver Forum for NASH and Fibrosis. Dr. Sanyal has authored more than 350 peer-reviewed publications and serves as chairman of the NIH NASH Clinical Research Network, the NIMBLE Consortium, and the Liver Forum for NASH and Fibrosis. He also served as a secretary as well as the president of the American Association for the Study of Liver Diseases. Our next speaker, Dr. Professor Quentin Ansley, is the chair of experimental hepatology and the deputy dean of research and innovation in the Faculty of Medical Sciences at Newcastle University in the UK. He is a practicing clinician, and he is also an honorary consultant hepatologist in the liver transplant unit at Newcastle's Freedom Hospital, where he leads one of the largest non-alcoholic fatty liver disease clinics services in the UK and, in fact, in Europe. He coordinates 2 major international research consortia that are studying NAFLD pathogenesis and developing and validating accurate biomarkers to assist in the diagnosis, risk stratification, and monitoring of patients with NAFLD and LITMUS, Liver Investigation Transfer Marker Utility and Steatohepatitis Consortia. Our third speaker, Dr. Mazen Noureddin, did his internal medicine residency at the University of Southern California and then moved to the National Institutes of Health here in Washington, where he enrolled in a 3-year hepatology fellowship at the liver disease branches of the National Institutes of Diabetes and Digestive Disease and Kidney Diseases. He is currently a professor of medicine at the Linda K. and David M. Underwood Center for Digestive Disorders, J.G. Walters Jr. Transplant Center, Sherry and Alan Conover Center for Liver Diseases and Transplantation at the Houston Methodist Hospital. He has conducted more than 50 investigational clinical studies of novel treatments for NASH and has published more than 200 peer-reviewed papers in many high-quality journals. Our next speaker, Dr. Laurent Castera, is professor of hepatology at the University of Paris in France and visiting professor of medicine currently at the University College of London. He received his medical degree from the University of Paris. His research interests focus on non-invasive methods for liver fibrosis assessment and NAFLD. He has published more than 200 papers in international peer-reviewed journals and serves as associate editor for clinical gastroenterology and hepatology, as well as in the editorial boards of the Journal of Hepatology, Gut, and Liver International. He has been the chairperson of the first international guidance on the use of non-invasive testing. And Dr. Timothy Morgan is currently director of the VA National Liver Disease Program, which oversees the policies and practice of liver disease care in the VA healthcare system. He is responsible for management of NAFLD in the VA, including criteria the VA uses to identify patients with NAFLD, as well as education of VA providers on identifying and evaluating patients with NAFLD risk factors, evaluation tests for the diagnosis and monitoring of NASH, and developing criteria for pharmacotherapy for the disease. He was the chair of the VA multidisciplinary group that released guidance for the management of NAFLD in the VA healthcare system in 2021. He has participated in pharma, VA, and NIH-sponsored clinical trials in liver disease for the past 30 years and has been the chair of DSMVs for multiple clinical trials. We hope that you will find these 4 talks stimulating, and I invite Dr. Sanyal to begin his presentation.
Thank you, Frank. May I have the first slide, please? Okay. So good morning, good afternoon, I guess. Good afternoon, everyone. And it is a great pleasure for me to present an update from the NIMBLE Consortium on behalf of all of the investigators. And I thank the FDA for giving us this opportunity. Next slide, please. So we've already heard that the histologic assessment has been the reference standard for evaluation of what we currently call MASLD. And the principal scientific premise for doing that is that the knowledge development for this condition, for its diagnosis, for assessment of prognosis, and disease monitoring and treatment response have all been anchored on histology. However, there's problems in paradigms. Histology is mired with, besides the fact that it is an invasive test and carries some risk, including a rare but real risk of mortality. There are other issues of observer variability, sampling variability, etc., that we've already heard about yesterday. But all of these have really provided the stimulus for looking at simpler, non-invasive tools that are more acceptable to patients and that are widely likely to be used in routine clinical practice to be integrated into the drug development paradigm. Next slide. But there are many unmet needs as we think about NIT development in MASLD. There's a paucity of qualified biomarkers. There's existing literature has many methodological limitations. A major barrier to access to care is the need for a biopsy, so we don't have a lot of patients to put into trials to validate these biomarkers. And of course, all of this creates an impediment for drug development. Now, when we think about biomarkers, one of the problems in the literature is that people frequently mix the intended use and try to lump them together, creating confusion. And it is important to separate out the diagnostic use of a biomarker versus its use for prognosis, for identifying prognosis, disease monitoring, treatment response, and eventually leading to surrogate endpoint, thereby creating sort of a hierarchy of evidence that is needed to eventually get us to where we want to be, where we can have a surrogate endpoint that can be easily measured in everyday practice and yet is robust enough to be used in clinical trials as an outcome measure. Next slide. As clinicians, we of course think a little bit differently. we ask ourselves in clinic, when we see a patient early in their course, is this person likely to develop fatty liver disease? When they come to us, we ask, is fatty liver disease present? And if so, is this the person who is going to get in trouble from the fatty liver disease? And what intervention is needed? And then once we intervene, is the disease trajectory changing? So where we think the greatest unmet need currently lies in the field is to identify not whether someone has excess fat in the liver, because the pretest probability of having excess fat, if you're obese and diabetic, approaches 70-75%. So that's really not the most important question in our view. What we want to know really is, are you going to get in trouble because of your liver disease? And that brings us to the concept of at-risk NASH, which is the person who not only has steatohepatitis, but has significant activity, which drives fibrosis, and where the liver has already started scarring down, i.e. have stage 2 or higher fibrosis. Next slide, please. So the NIMBLE Consortium, which is a public-private team science effort by the FNIH, has a couple of overarching goals. First, to diagnose and stage NASH, and of course, its individual subcomponents. And next, to measure the response to therapeutic intervention or a response over time. And so the idea here is that we would be able to translate some of these biomarker needs into high priority contexts of use, particularly to identify at-risk NASH, and the subparts of which are to diagnose the underlying presence of steatohepatitis, and also to determine the stage of the disease and the level of activity. And then, of course, to be able to identify if the disease stage and activity are changing over time. Next slide. So we broke this project into 2 stages. In the first stage, we had two subparts, one looking at circulating biomarkers, the other at imaging biomarkers. And we looked at circulating biomarkers, relating them to histology as the reference standard, albeit imperfect. And then on the imaging side, we looked at a number of ultrasound-based and MR-based biomarkers. The goal of stage 1 was to get us to a point where we could be quite sure that we have a robust readout of sensitivity, specificity, and we can address some gaps in knowledge that are essential and foundational to really validate these biomarkers. And that's more relevant for the imaging piece. For the circulating piece, we really wanted to get a robust readout of sensitivity and specificity. Next slide, please. So here are the original set of biomarkers that we plan to study. Now, remember, at the time that we started NIMBLE, we did not have the ADAPT score. We did not have Agile 3, Agile 4, even the FAST score did not exist. So this is based on what was a priori set in place, and it shows what are the components of at-risk NASH that these individual tests were supposed to provide a readout for. Next slide. So here are the data for NIS4. NIS4 basically includes 4 different components with MIR34A, alpha-2 macroglobulin, and a couple of other biomarkers. And over here, it was designed specifically to diagnose this composite diagnosis of at-risk NASH, which is NASH with a NAS score of 4 or higher and fibrosis stage 2 or higher within an NAFLD population. Now, the stage 1 circulating biomarker studies were done in a cohort of patients that were curated from the NASH Clinical Research Network larger database registry population. It was curated to make sure that we had a relatively even distribution of fibrosis stages to avoid spectrum bias based on fibrosis. The other thing we did was all of the biomarkers were tested on the same blood sample drawn at the same time in very close proximity to the biopsy. And so that there was no variability based on one sample being tested far away from a biopsy, another biomarker being tested closer to the biopsy in the same patient. We had two core principles that we wanted to use as gating steps in stage one. One, that we would have an OROC of 0.7 or higher, and then next, that you would at least beat some common clinical aids for the same context of use. So for NIS4, this would be for at-risk NASH, we had FIB4 and ALT, and we wanted to make sure that they would at least robustly beat both of those. And as you can see over here, NIS4 did exactly that. It had for at-risk NASH, had an OROC over 0.8 and was superior to the OROC for FIB4, and similarly was actually superior to ALT as well. So it met the criteria for our stage one to move further ahead towards a more full qualification plan. Next slide. Similarly, the next one was that I show you here is the ELF test. And this is specifically just for the various types of fibrosis stages. And we looked at clinically significant fibrosis greater than stage 2, advanced fibrosis, which is stage 3 and 4, or cirrhosis. And for each of these, you have the OROCs, as you saw, as you progress from clinically significant towards cirrhosis, the OROCs progressively improved. Now, interestingly, the OROC for FIB4 improved as well. But at each stage, ELF outperformed the FIB4, and certainly for cirrhosis, had a sensitivity and specificity of 82 and 73% respectively. And so this really gives us confidence that for a diagnostic enrichment context of use, we're getting very close to being able to use some of these tests to identify if somebody has cirrhosis. Moving on, next slide. And similarly, for fibrometer VCTE, you can see that for diagnosis of cirrhosis, again, it outperformed FIB4 for all three cutoffs for fibrosis, and for cirrhosis, approached an OROC of 0.9. So we're really beginning to make some serious progress in terms of validating rigorously some of these biomarker panels as to identify specific subphenotypes of the larger MASLD population. Next slide. And then this is a post-hoc analysis of the ADAPT score. And you can see over here, it was superior to FIB4 for clinically significant fibrosis, but its performance declined as you progressed to cirrhosis and was no longer superior to FIB4 when you got to cirrhosis. And unfortunately, because of time, I'm not going to be able to show you the data for AGILE, but we can talk about it during the panel discussion. Moving on, next. Next slide. Then we, over here, again, we looked at, this is just based on liver stiffness, which is a ultrasound-based biomarker. And you can see again over here what these scores are. We don't have time to discuss this at great length. Next slide, please. So this brings us to the imaging biomarkers. And here we had two different studies. And what we found upon doing sort of a systematic review of the literature was there were some foundational gaps in knowledge about the repeatability, reproducibility, and whether the data that you got across one platform was comparable to that across another platform. And so we tended to focus our imaging work on those two unmet needs. Next slide. So we developed these precision metrics working with Nancy Obachowski, who was a statistician for this, and essentially provided a different operator reproducibility coefficient. The data for some similar circulating bio tests that we use every day in routine practice are showed in the table on the right as well. And you can see that for bilirubin, it approaches almost 23%. Next slide. And for ultrasound, we looked at a bunch of biomarkers, but I'm going to focus on shear wave elastography and VCTE because these are the two most commonly used things in that are being used in clinical trials. Next slide. And what you see over here, we looked at a bunch of different vendors for shear wave elastography, and without going into their individual names, as you can see, the data for each one's shown in this table. And if you look at the pooled RDC, it approaches about 30%, and the confidence bounds are provided around it. So what this says is that changes in shear wave as over 30.7% can be considered a real change with about 95% confidence. Next slide. And essentially, you can see how all of these data actually, when you look at the reproducibility coefficient as well. Moving on, next slide. And when you look at VCTE, once again, you see the RDC is about 35%. Next. And you can see the reproducibility coefficients also shown over here. So once again, it shows that you have to have a fairly substantial change in these elastography parameters to be absolutely confident that you're measuring a true change. But at least now we have numbers that we can hang our hat on. Next slide. Moving on to MR-based biomarkers. Again, we looked at a number of biomarkers, but we'll focus on a handful which we think are most used in clinical practice. Next slide. So here are the data, again, shown in similar format. And you're looking at visceral adipose tissue, 2D MRE, 3D MRE, PDFF. And you can see over here that visceral adipose tissue measurement was very accurate with only 3.3%. And even the PDFF variance was quite tight, and under 10%, whereas the MRE ranged from 19.7 for 3D to about 24% for 2D MRE. Next slide, please. So all of this has now put us in a place where we know for these imaging tools, how much is the variance. And we're looking at the existing literature to see if there are well-defined and robust cutoffs for diagnostic enrichment purposes. And this is going to be combined along with our circulating biomarker work to inform stage 2, which is going to focus primarily on nailing down the diagnostic enrichment context of use. And a set of qualification plans for these individual circulating biomarkers are already underway. And a UO1 has been put in place between the imaging work stream and the FDA to work on the analytics of how to proceed forward with some of the imaging biomarkers. Next slide. Then, of course, we want to extend what we have done towards prognostic and disease monitoring contexts of use, leveraging our collaboration with the NASH CRN, and relying mainly on industry partners to provide data sets for to look at treatment response biomarkers. Next slide, please. Now, as we finish, and thinking about disease monitoring and treatment response biomarkers, I think it is important that we give this considerable additional thought. For example, our current reference standard of how we define a resolution of steatohepatitis, requiring ballooning to become 0, I think is flawed. Because if you look at the top panel of the histology, you can clearly show that post-treatment, the biopsy on the right looks much better than the one on the left. Yet, if you look close enough, you probably will find a balloon cell. Given all the problems with ballooning that you've heard about, maybe we should revisit this. Similarly, if one of the reasons to use histology as the reference standard is that it gives us prognostic information, then we already are getting an increasing number of studies showing that NITs can provide prognostic value that is at least as good, and in some cases even slightly better than histology. So that has to be taken into consideration. And if prognostic utility is the basis for consideration as a surrogate, why not link the validation directly of these to the outcomes? And a key issue, of course, is to look at sensitivity to change and identify how much of a change is a clinically meaningful change. And I think that's really where the rubber will meet the road. So with that, I think I will conclude. Last slide. I would like to acknowledge all of the people who have contributed to the data that I just showed you, without whom, and the patients who provided their samples and allowed us to study them, without whom none of this would be possible. Thank you for giving me the opportunity.
Thank you very much. If I could have my slides, please. So it's a great pleasure to be here, and I'd very much like to thank the FDA for organizing this really important two-day meeting and also the opportunity to participate in it. I've been asked to talk a little bit about the use of NITs as diagnostic biomarkers and to assess treatment response in non-cirrhotic trials, the perspective of the Litmus Consortium. Next slide, please. These are my disclosures. Next slide. So just by way of some background, it's worth understanding a little bit about what the Litmus Consortium is. So Litmus is funded by the European Union through the IMI2 funding scheme. And very much as you've heard with Nimble, it's a public-private funded partnership. Litmus was tasked with implementing a robust technology unbiased platform to conduct the systematic study and validation of a broad range of non-invasive biomarkers and imaging technologies with reference to fully adjudicated liver biopsy data. And Litmus has addressed a number of different target conditions. The first one, at-risk NASH, so NAS greater than or equal to 4 with fibrosis greater than or equal to 2. The second one is actually clinically significant fibrosis, which is F greater than 2. And the third one is the target condition of advanced fibrosis, defined as fibrosis greater than or equal to 3. And it's followed a multi-stage process. The first step was a series of authoritative systematic reviews and individual patient data meta-analyses, many of which have been published. The second step was direct biomarker assessment in a large extant cohort, which is the Litmus meta cohort, and I'll show some of that data. And the third step is the further validation of a range of biomarkers in a prospectively recruited, highly monitored cohort, the Litmus study cohort. And we're very excited because we've just completed full database lock on that, and data will be coming out in the very near future on that one. One of the key features of Litmus is the robust platform that's been implemented. And as you can see in the cartoon here, the red border identifies what's called the Litmus firewall, which ensures that all measurements of biomarkers are performed without knowledge of the biopsy results or extraneous clinical information, to make sure that all data analysis, therefore, that flows forward into our publications and our qualification packages are of the highest possible standard. Next slide, please. The Litmus cohorts are based on the European NAFLD registry, which follows a unified protocol across 13 countries. It's a very comprehensive clinical data set with a robust quality management framework using a risk-based approach to source data verification on site and central monitoring. We also have central reading of all liver biopsies, a clearly defined chain of custody for biological samples and imaging data, and a great deal of work has been done to minimize pre-analytic variation through standardized SOPs and handling both at sites and in our centralized biobank in Luxembourg. And there's been a lot of work done also to determine precision, accuracy, and other markers of the assays that are being performed. Next slide, please. So if we start off with the systematic reviews and meta-analyses, this is just a sample of those that Litmus have performed, addressing predominantly the diagnostic context of use, but also some looking at the prognostic context of use. Next slide, please. Just to pull out one example from that, this is the meta-analysis performed on the ELF test, looking at over 4,500 individuals. And what we've been able to do in each of these studies is model a range of different thresholds for diagnostic performance, but also to look at performance across a range of different pre-test probabilities, in other words, disease prevalence. And this allows us to get a greater understanding of the performance and then take this information forward into our further studies. Next slide, please. Moving on to the analysis of the litmus meta cohort, here you can see the results that were published earlier in the year in the Lancet Gastroenterology and Hepatology. It's worth noting that a slight difference between the litmus approach and the nimble approach is that we've adopted NAIROC of 0.8, whereas, as you've just heard from Dr. Sanyal, they've adopted NAIROC of 0.7. And there are also slight differences in the disease distribution between the cohorts, with the litmus cohort having a leftward skew more similar to what you'd see in a secondary or tertiary care setting. What we can see with this is that two particular biomarkers for fibrosis crossed the 0.8 threshold, which were the SOMA signal tests, and also the ADAPT score, which is based on PRO-C3, with a number of others approaching but not quite reaching it, examples being ELF test. Next slide, please. And one of the other things we've also explored is how to use the biomarkers to assist with pre-screening for clinical trials. And so here you can see thresholds being tested and the performance of a range of these different biomarkers to identify the smallest number of individuals who need to go forward for liver biopsy to make pre-screening as efficient as possible. Next slide, please. So, with that in mind, I think we've got quite a lot of data to support the diagnostic context of use. But I'd like to take a few moments to think about what are the considerations one needs to consider regarding assessing disease response or pharmacodynamic context of use. And this is really talking about biomarkers to be used as surrogates. And there's this very helpful document that was produced by the FDA a couple of years ago. And I'd just like to work through some of the key points from this in terms of the relationship of a surrogate endpoint to clinical outcomes. Next slide, please. So the first point here is to consider whether a potential surrogate endpoint has biological plausibility. Next slide. The next thing to consider is what evidence is there that supports a relationship between a potential surrogate endpoint and the clinical outcomes of significance. Next slide. And then we need to consider, do changes in the surrogate endpoint reflect true changes in that clinical outcome? And what is the extent and timing of the changes in the surrogate endpoint that would then predict these outcomes of interest? Next slide. Finally, we need to consider whether the current surrogate is adequate for use. Next slide, please. And I think this is something I'd like us to come back to, I hope, in the discussion, because of course we need to consider that there are two concepts behind surrogacy. There's that generally accepted surrogate or full surrogacy endpoint, but then there's also that likely accepted surrogate, which is what we use histological change for now in current phase 2 and phase 3 trials. So I wonder whether we need to consider what level of evidence would we accept to adopt a new likely accepted or reasonable surrogate. And that's something we can come back to. Next slide, please. So let's start off by considering the current standard, which is histology. Next slide. So I won't spend too long on this, but we've seen a lot of data that suggests that the use of histology to assess therapeutic response has some challenges, in particular inter-observer variability, which can reduce the statistical power of clinical studies. And this was a very nice study published a couple of years ago now by Davison et al., which demonstrated how even amongst 3 pathologists, the kappa values can become compounded, particularly when you're considering steatohepatitis. Next slide, please. The other piece of evidence which has emerged in the last couple of years is the substantial inter-observer and indeed intra-observer variation in terms of identifying ballooned hepatocytes. And as we all know, the ballooned hepatocyte, the presence or absence of it is the defining feature for that loss of steatohepatitis. And so these findings are of significant concern regarding that current endpoint, where 9 of the world's leading pathologists looked at 10 slides and identified every balloon cell each working independently. Next slide, please. The striking feature about this, above and beyond the degree of variation, is that for almost every single biopsy that was examined, we could find some of these world-leading pathologists who would say there was no ballooning present, and other world-leading pathologists who would say that there was. And there was also evidence of a disconnect between the identification of ballooning being present or absent and their gestalt opinion about steatohepatitis. So really, I think we need to consider this ballooning issue quite carefully when we consider surrogates. Next slide, please. So let's go through the 4 other points. First of all, biological plausibility. Next slide. And on again to the next slide, please. So if we think about fibrosis here, there are a range of potential biomarkers that we can use. There are the indirect serum biomarkers, and then there are the direct serum markers. Certainly a number of the indirect biomarkers have biological plausibility because they reflect fundamental biological processes that underpin steatohepatitis, such as apoptosis or necrosis, as is the case with CK18. Next slide, please. But the direct collagen biomarkers have particular biological relevance because they reflect that balance between fibrogenesis and fibrolysis. And so we can think of those certainly as relevant and biologically so in the diagnostic context of use, but because they also reflect this dynamic balance, are also potentially of high biological relevance for monitoring and pharmacodynamic response. Next slide, please. If we think then about the evidence that supports a relationship between non-invasives and clinical outcomes, next slide, please. We have a wealth of data that's building up. So here I'm showing you an individual patient data meta-analysis from Litmus, again published earlier this year, which looks at histology and then 3 non-invasive biomarkers, FIB4 and the NAFLD fibrosis score, so simple panels, and FibroScan VCTE. And all of these demonstrate clear prognostic utility. In other words, a link between the biomarker and outcomes. Next slide, please. Looking at data from the STELLA studies, the same can be said for the ELF test, which very nicely was able to demonstrate long-term outcomes. And of course, these were the data used to underpin the FDA's marketing authorization for ELF as a prognostic biomarker under their IVD pathway. Next slide, please. If we move on then to think about whether changes in potential surrogates reflect changes in outcome. Next slide. We also have mounting evidence here to suggest that NIT change is biologically relevant. Now, we've presented data at AASLD on this point using the UK CPRD primary care databases, but I'm showing you the data here from a full publication from Hans Hagram's group, again in a large population cohort, showing that change in FIB4, in other words, sensitivity to change, allows you to adjust prognostic prediction of outcomes. So strong evidence for this same process. Next slide, please. And again, using those STELLA data sets, we also have evidence that change in ELF score, change in the NAFLD fibrosis score, and change in liver stiffness by FibroScan can again predict change in outcomes and effect hazard ratios. So in each of these cases, we're beginning to get information that fulfills that 3rd criteria. Next slide, please. The final criteria, and possibly the most difficult one to address, is to what extent and what timing of a change in a surrogate predicts outcomes of interest. Next slide, please. Now, we haven't made this easy for ourselves, and the reason I'm showing you this is a summation of the non-invasive tests that have been used across a range of the larger clinical trials that have been reported to date. And what you can see is that there's a lack of consistency with which non-invasive tests have been used. And I think one of the things we need to do here is generate more data, as we've already heard during the course of the day, regarding how much change is sufficient change, and what timing of change. And the best way to do that is to start to mandate a set of biomarkers that we expect to see in clinical trials going forward. Next slide, please. There are, however, some learnings that we've already established. Now, I think the FIB4 score is a fantastic tool for the diagnostic context of use. But it's also true to say that not every non-invasive biomarker that is good in the diagnostic context of use can necessarily be applied as a pharmacodynamic or response biomarker. And I'm afraid to say I think that may be the case with simple panel tests like FIB4, like the NAFLD fibrosis score, etc. And the reason for that, and I'm just going to illustrate it with data from one trial, which was the REGENERATE trial, but we can see this in lots of other studies, is that there's often a very rapid drop in ALT very early on, maybe within the first 2 or 3 weeks of a study. That's what was seen in REGENERATE. And of course, that reads through into very rapid improvements in scores like FIB4, APRI, etc., far sooner than there will have been a change in fibrosis. And so I think we need to remember that drops in these simple panels are likely to be driven by those ALT changes, not fibrosis regression. And so they probably can't be used as a response biomarker. Next slide, please. We do, however, have increasing evidence, more needed, but increasing evidence that regression of fibrosis biomarkers, whether that's liver stiffness, elastography, in other words, here using FibroScan data in the STELLA studies, or biomarkers like ELF, may well indicate improved outcomes. So we're beginning to see this data set build up. Next slide, please. I think right now, we have to accept that there isn't a perfect biomarker. That's true for histology. It's also true for the non-invasives. So it's then a question about, well, what is our strategy to use those biomarkers in clinical trials to give us robust evidence of therapeutic benefit or lack of therapeutic benefit, and also to advance the field and move things forward. And I think that there are already a couple of things we can do here to take that forward. The first is we need to consider global assessment of biomarker response. It's important to demonstrate regression of disease, and that's what I'm illustrating with the waterfall plots on the left, but also to demonstrate that if a treatment is efficacious, there will be less progression of disease. And it's important to consider both sides of that coin. The other thing I think we need to bear in mind is the assessment of consistency of biomarker changes at the per patient level. So, and here we're using the Venn diagram concept on the right. I think we need to assess individual patients and see, for example, improvement in 3 different biomarkers for the highest level of evidence and 2 out of 3 biomarkers for a secondary level of evidence of improvement, with all of these having levels of change greater than established coefficients of variation for these tests. And I think these are approaches where, in the absence of a single perfect test, we can get a closer approximation to the ground truth. Next slide, please. So, by way of conclusions, first and foremost, I think liver histology is an imperfect biomarker, and histological assessment of ballooning, and therefore NASH resolution as it is currently defined, is a scientifically untenable trial endpoint. If we think about non-invasives, we have now good evidence that we have a range of tractable non-invasive biomarkers that are available to support drug development, particularly in that pre-screening phase. When we think about pharmacodynamic or response biomarkers, we do still have some work to do here. There's a lack of consistency of NIT adoption and reporting in clinical trials. And we certainly therefore need to develop more data here and define clinically meaningful magnitudes of change. I think as a priority, we should come together and define a set of NITs that are mandatory for measurement and reporting in future clinical trials. And I think in the absence of a single perfect biomarker, we need to assess those global assessments, looking at consistency of response at the per patient level to using an established set of biomarkers so that they internally reinforce each other. When we think about surrogacy, there's already some evidence that fibrosis biomarkers have prognostic value, and indeed that change relates to change in outcome. But we need further data on that. And one of the thoughts here is that, as I've mentioned already, and as we all know, we currently use histology as a likely accepted surrogate in the reassurance that we go on and follow up for outcomes. Maybe we already have enough evidence to start using NITs as that likely accepted surrogate, again, with that safety net of the outcome follow-up to go forward. Something I hope we can discuss. So to conclude, the current histology-based drug development paradigm was founded in 2013, and now a decade later, with substantial advances in our understanding, it's time to review that and reconsider options. To put it another way, last week, the iPhone 15 came out. None of us are still using an iPhone 4, which was the iPhone of choice in 2013. And certainly, none of us are using the telephone that Alexander Graham Bell advocated in 1875, which was about the time that H&E was first put into the literature. It's time to reconsider with what we now have available to us. Thank you very much indeed.
Get started. Thank you very much. Next, first slide. So I'd like to thank the FDA, Dr. Anania and colleagues for inviting me to be part of this important workshop, which has been great thus far. So my task in the title is identifying knowledge gaps of circulating serum biomarkers in two areas, diagnostic biomarkers and to assess treatment response for non-cirrhotic MASH trials. My conflict of interest, I have helped sponsor designing clinical trials as well as diagnostic tests. I've developed many diagnostic tests, including serum, machine learning, as well as imaging. Next slide. So again, this is the objective of my talk. I'm going to talk about the serum NIT in particular, and Dr. Castera will follow with the imaging. And those are the final two talks. So I'm going to tell you again how we got here, which will be emphasis on many of the previous talks that my colleagues presented. So on the left is the first task. I'm going to talk about the fibrosis staging, and more importantly, a concept we moved to recently, which is at-risk MASH. I'm also going to touch base on the monitoring response to therapy. And I appreciate yesterday the point was brought up by Dr. Anania and Heller that there could be a point of tension. But I think we have to come to our agreements. And I think one of our agreements that we all agree that whatever we do, it should lead to patients' well-being and predicting clinical liver events. Next slide. So I'm going to take you to this welcome effort by the FDA and the hepatitis C field. And I'm going to read a sentence from you from an NDA document or paragraph. It says the following for assessment of efficacy endpoints in hepatitis C. Evaluating clinical outcomes in prospective randomized controlled trials of chronic hepatitis C is challenging because of the difficulty of maintaining patients on a randomized arm without intervening therapy for a sufficient duration, between two brackets, many years, to identify clinical events such as hepatitis C or liver transplantation. However, multiple observational cohorts show correlation between SVR24 and improvement in clinical outcomes, such as development of HCC, hepatic events, fibrosis, and all-cause mortalities. These observational data support the use of SVR as a validated surrogate of HCV disease progression. I do appreciate Dr. Stein's talk yesterday that he showed us what is needed to define NIT as reasonably likely surrogate endpoints, including randomized controlled trials as well as observational study. I do also appreciate the many facts that people said this is not hepatitis C, this is a more complex disease and it's metabolic disease. Nevertheless, what we know today that fibrosis progression lead to outcomes and steatohepatitis is the engine that lead you to that. Next slide. So where we started, the NASCRN put a histological score to identify patients that they should go into clinical trial. In another welcome effort by the FDA, we defined primary endpoints for phase 3 studies more than a decade ago. And those were NASH resolution and fibrosis improvement, making our best judgment that those correlate with outcomes. Next. At that point, non-invasive biomarkers were thought to be a surrogate of a surrogate, which is histology, that correlate or can predict outcome. Next slide. So again, I'm emphasizing on points that were made earlier. So let's see what happened to fibrosis improvement over the year. In 2015, landmark paper by Angulo showed F2 and higher correlate with outcomes and can predict outcomes. Indeed, Zubair Younasi showed that 3 years prior to 2015 and 2012. Next. More data started coming out. This is European data published in JHEP, also showing with F2 and higher, you have more likely risk for morbidity and mortality. Next. A meta-analysis by Newsom and colleagues showed, published in Gastroenterology, showed patients with F3 and F4 are the highest risk for liver-related outcomes. But as I mentioned, there are data on the F2 and higher, and that's why we start earlier in clinical trials. Next. And importantly, the NASCRN clinical outcome study came out just 2 years ago, after many years of this network ongoing, because outcomes take time. And what they showed in this prospective study published by Sanyal and colleagues in New England Journal in 2021, that the F3 and F4 patients are the highest risk for clinical outcomes, clinical liver outcomes. However, earlier stages such as F2 is the point for starting because we have data on them. Next slide. Along the last decade also, we learned that assessment longitudinally could have problem. And this is the fibrosis regression that mentioned by many. The unweighted kappa for the pathologist to agree on this is 0.366, very low. So it's probably, we don't need more efficacious drug. It could be that problems like this was the reason to hide some efficacy. Next slide. Indeed, if you look at the very first evidence that lack of fibrosis progression is predictive of better outcomes, this data was just published 2 years ago, again by Sanyal and colleagues from some of the Gilead trials, showing you if you have improvement or lack of progression, you're more likely to have good outcomes or less clinical liver events. Next slide. Moving to NASH resolution over the years, 2010, I took it as the landmark PIVENT paper, and we were talking about 2-point NASH improvement. We talked about NASH resolution, but the primary endpoint was mostly focusing on 2-point NASH improvement. Next slide. Another study by Kusi and colleagues looked at pioglitazone and also focused on 2-point NASH improvement. And those were the substance for guidelines recommending both pioglitazone and vitamin E. Next slide. Indeed, also important data from the NASCRN showed you that NASH improvement or 2-point NASH improvement, more also on the NASH resolution, either one of them can lead to fibrosis improvement. Next slide. Nevertheless, more recently, and Quentin showed this very nicely, we started questioning ourselves, is NASH resolution the way to go? There's huge disagreement on the ballooning cell as it's here. And I'm not going to repeat what Quentin said, but next slide. Again, I'm an investigator. I will show you an example that Naeem mentioned earlier, and I face it every day. I had 2 patients this month like this. This is from actual patient from clinical trial. He has steatosis grade of 3, has lobular inflammation of 1. He has no ballooning. His score is 4, which the score itself will qualify him, but the ballooning did not qualify him. Importantly, he's F3 patient, the same patient we talked about that he can have clinical outcomes. This patient was excluded from clinical trial. I had another patient like that. Of note, this month, of note, the local reading was NAS of 5 and the ballooning was positive. I do wonder how many patients like that we're excluding from clinical trials and what will happen for them until we have drug approved. Next slide. Also for the NASH resolution, the same story, assessment longitudinally. Here you see the unweighted kappa also on the low side. Next slide. So let's talk about the diagnosis. So the fibrosis and at-risk MASH. Next slide. Here, my task is to talk about serum non-invasive testing, and I want to go to the highest evidence, which was recently published and agreed on in the AASLD guidelines. My task is to talk about serum. I'm going to talk about FIB4 and ELF. I will leave to the rest to Dr. Castera. And in these guidelines, on the left, they identify cutoff for advanced fibrosis, F3 and higher, or cirrhosis on the right. I'm going to touch base slightly on promising biomarkers such as PRO-C3, and I'm not going to talk about biomarkers that are not used as much before, that such as NAFL fibrosis score and APRI, and Dr. Sterling talked about those in details. Next slide. So the ELF has been already vetted earlier, but what I want to add also or emphasize on that this is FDA approved based on prognostic value. More than 9.8 predict progression to cirrhosis, and this is important clinical endpoint. And more than 11.3 predict clinical liver outcomes. Next slide. In addition, we have data after data showing that if you do sequential testing or you do more than one NIT, you increase your confidence of the test. Next slide. And at-risk NASH has been also discussed earlier. I go back to the AASLD guidelines, and they are mostly imaging based to predict at-risk MASH. So there's FAST, there's MAFIB, there's MAST, CT1. But I want to emphasize a point that they have lab values or serum values with them. So they are combining multiple things to increase accuracy and precision. Next slide. I want to mention tests that they are coming. For instance, the NIS2 score that was just published in JHEP showed a good area under the curve in predicting at-risk MASH, and this is serum-based test. I'm not going to go into details. We need more data for validation. Next slide. Again, for disclosure, this is data we developed, but multiple people on this call and internationally were involved in this metabolomic-based test that had 1,200 patients to predict at-risk NASH. And this, again, need more data. So there are more serum blood tests that they are coming out there. Next. Let's talk about response to therapy. And basically what we have had thus far comparing to histology. Next. So this is a paper published in Gastroenterology in 2019 showing ALT changes predict histology. And we know that in hepatology from a long time ago. Next slide. And in my mind, this is one of the most important papers in terms of assessment treatment response, published in JHEP. Change in ALT, AST, FIB4, and transient elastography in the next slide did change the same direction histology changed. If it improved, it worsened, it stayed the same. But I think the authors had a very good statement in this paper. Area under the curve value for each of these were suggestive of only weak association. So the question number one, why they were not combined and what do we need to combine? Next slide. I talked about this already. Next slide. Also other data showing here, for instance, this is from resmetirom data from Lancet 2020, change in PRO-C3 moved the same direction like histology, change in ELF moved the same direction like histology. Next slide. FGF21 data showing you also, this is a Nature Medicine paper showing you the liver enzymes are moving the same direction like histology. Next slide. Same paper showing you that PRO-C3 ELF are moving the same direction. Next slide. And a recent New England Journal paper also showing you ALT, ELF, PRO-C3, and PDFF, which is imaging, are moving the same direction with histology. Next. Indeed, other New England Journal paper showing you biomarkers as simple as liver enzymes move the same direction like histology. Next. I do think we need more data on that part of the talk. meaning correlation between NITs and histology, but does not matter. I think the elephant in the room is, are NITs, such as serum NITs, are reasonably likely to predict clinical liver events? And this is what we need to come and answer with. Next slide. This is data from almost 1,000 patients or 1,000 patients from the Gilead program that showed baseline ELF NAFL fibrosis score and FIB4 VCTE predicted or correlated with progression of cirrhosis and predicted clinical outcomes. Next slide. Also, this mentioned earlier, FIB4 not just at baseline, longitudinally and changes over time. FIB4 does predict clinical outcomes. It has its own issue. Dr. Sterling touched base on that, but it does correlate with outcomes. Next slide. Again, back to the ELF. It was approved based on prognostic data. Level more than 9.8 predict progression to cirrhosis. Levels more than 11.3 predict decompensation. Next slide. So where are we today? I think we started with NASH resolution and fibrosis improvement with a welcomed effort to move the field forward. NASH resolution is not panning out to correlate with clinical outcomes. Nevertheless, it's the engine, so we know that very well. But many of us think that the surrogate or NITs have reasonably likely data to correlate or predict outcomes. Next slide. And it's important to put things together. So serum biomarkers should not be used alone, probably at the first step. Indeed, Dr. Castera is going to have a presentation on imaging, but there are tons of data more on the imaging side showing that imaging do predict clinical outcomes. For instance, the VCTE of 20% changes did predict changes in outcome. Now, 20% has been argued, and I'll leave that to Dr. Castera, so we can raise the bar here to more than 20%, 30% and more for the variability. Next slide. So this is not by any means a proposal or a figure that shows how things needs to be done. This figure next is going to ask why we don't have these discussions and we agree what is doable and what's not. We started with NASH resolution and fibrosis improvement for primary endpoint for subpart H. Next. What we have seen, fibrosis improvement is the one that predict clinical outcomes. Next. Again, this is not a proposal. I think we need to have this discussion. Depending on the MOA, for instance, if you have metabolic versus inflammatory fibrosis, let's take inflammatory fibrosis drug mechanism. Things that can be done, an example, VCTE changes more than 30%. Dr. Sanyal raised it to 35%. We can discuss that. And decrease in ELF to less than 0.8 and change in ALT. Again, those are points for discussion. If we have MOA that focus on metabolic, we can add MRI-PDFF. Next slide. Next. And this is not coming from nowhere. There are a bunch of data in multiple presentations today, and in the next one, showing all these that are suggested here do predict clinical outcomes. Next. And as a reminder, it was discussed earlier, we're just asking to do that in subpart H. And then the trial will continue to clinical outcomes. Next. So benefits of switching to NITs: mitigate subject risk, increase enrollment, that my patients got excluded. It's ranging now between 60 and 80% screening failures. Some of them are F3s. Inter and intra-observer variability will be mitigated, and NITs are reasonably likely to predict outcomes and could be reasonably likely surrogate endpoints. Next. In conclusion, NASH resolution has issues. It have been emphasized today in multiple talks. Serum NITs have made a significant progress since the last assessment for NASH/MASH RCT endpoints more than a decade ago. Imaging NITs have even made greater progress. but we need high level evidence so we make sure we are doing the right thing. And many of us mentioned today that can be done with a combination of NITs that we sit down and agree on based on evidence. And finally, if more data are needed, especially with correlation with outcomes, we need to spell that out all together today and the subsequent conferences and decide what is right for the patients. Thank you very much. And I think I'll pass the mic now to my colleague and friend, Professor Laurent Testera.
Good afternoon. First of all, I would like to thank the FDA, Dr. Mehta and Dr. Bundukwala for the kind invitation to deal with knowledge gap of Imagine NIT. These are my conflict of interest. During my talk, I'm going to discuss how we can integrate Imagine NIT non-cirrhotic NASH drug development. As for diagnosis, there are two aspects: enrichment and full diagnostic. Don't forget, context of use is one of the critical issues when using non-invasive tests. Strategy and tools depend on the context of use. This holds true for enrichment of population that target primary care, where the prevalence of fibrosis is very low, less than 5%. For this purpose, sequential algorithms combining FIB-4 and VCTE are effective for advanced fibrosis. This has been shown recently by a large meta-analysis from the Litmus, and you can save liver biopsy in more than 65% of the patients. Accordingly, 4 international guidelines currently recommend sequential algorithms, starting with the EASL guideline. And basically, they recommend FIB-4 as first test, and then VCTE or ELF, and they're all aligned, which is a very good sign. As for full diagnosis, this deals with liver clinic, where the prevalence is much higher, 20 to 30%. This table summarizes the meta-analysis regarding Imagine NIT, and as you can see, their performance for NASH is far from optimal, with some meta-analysis concluding that they are unreliable based on small number of studies and limited number of patients. On the contrary, they have high performance for fibrosis, not only significant fibrosis, but also advanced fibrosis with a ROC ranging from 0.85 with VCTE to 0.92 with MRE. Nevertheless, VCTE has the highest level of evidence and number of patients. Interestingly, liver stiffness at baseline can predict clinical outcome as well as liver biopsy NAFLD, has been shown in this recent meta-analysis that has already been presented. The same holds true for MR elastography, where liver stiffness can predict liver-related event. What about the cutoff? We should use a dual cutoff strategy with a rule-out cutoff with high sensitivity, high negative predictive value, and with cutoff between 6.5 and 7. A rule-in cutoff with high specificity, but as you can see, the positive predictive value is suboptimal, ranging from 71 to 74%, meaning around 30% of false positive. As for the risk of positive, the LSM confounder are well known: inflammation, operator inexperience, excessive alcohol intake, and obesity. Obesity is associated with a high failure rate ranging from 70 to 40% in patients with BMI above 40, and unreliable result as well in the remaining patients. What about composite score for advanced fibrosis? AGIL-3+ has been recently proposed, combining LSM and clinical and biological parameter. And as you can see, is this large retrospective multicenter study. AGIL-3 outperformed both LSM and FIB-4 in terms of OROC, but also regarding the number of indeterminate results that was lower. This result remained to be further confirmed. What about composite score for identifying at-risk NASH, FAST, MAST, and MEFIB? This table summarizes the performance of the index study. I want to stress a few points. First of all, at-risk NASH prevalence was highly variable from a study to another. Gray zone ranges from 18 to 30%, and PV was very high. On the opposite, PPV was suboptimal, 50 to 70%. And finally, the percentage of correctly classified patients were ranging from 57 to 72%. FAST has, however, the highest level of evidence as shown by this meta-analysis. Gray zone in around 30% of cases, better at ruling out than ruling in at-risk NASH. We're lacking independent head-to-head comparison. This is what we have done in type 2 diabetes patients, the so-called QUID-NASH project in 250 diabetic patients with liver biopsy. FAST and MAST score outperform MEFIB using OROX. But when looking at correctly classified patients, this was to the advantage of MAST, with around 70% of patients correctly classified as compared to FAST and MEFIB, and this was related to the smaller gray zone with MAST. So in summary, for enrichment of population, sequential algorithm works well and are recommended by international guideline. As for full diagnosis, elastography is a tool of choice not for NASH but for fibrosis and predict liver-related event. Dual cutoff strategy should be used. Reliability of VCT in patients with BMI above 40 is an issue. And composite score for at-risk NASH are promising, but further independent validation is needed, especially in at-risk non-cirrhotic NASH. Now, what about treatment response? We don't have any surrogates of treatment responses in NASH like HCV-RNA or A1C or LDL cholesterol. Changes above 20% in liver stiffness using VCT have been shown to predict outcome in F3 F4, but the question is whether changing is liver stiffness predict fibrosis regression. What can we learn from the viral hepatitis field where most data are coming from? As you know, HCV eradication or HBV suppression are associated with fibrosis regression and decrease in overall mortality. This meta-analysis has shown a significant LSM decrease in SVR as compared to non-responder in HCV. However, it's the available study had many caveats, including retrospective, small sample size, many interferon-based, short follow-up, and most importantly, no paired liver biopsy. These are data in hepatitis B, and as you can see, there was a two-phase decline with virus suppression, fast decline within 24 weeks, related to the ILT normalization and likely related to inflammation, and a second decline that it was much slower, likely related to fibrosis. Interestingly, liver stiffness decrease over time was associated with lack of occurrence of liver-related event. However, HCC surveillance still recommended in this patient. Now, what about NAFLD? So, fibrosis regression has been shown to be associated with a decrease in MALO and liver stiffness using VCTE in NAFLD, even though this study has some shortcoming with a short follow-up and a low incidence of MALO, but very important study still. What do we have now in trial? These are the REGENERATE data, and you can see there was a LSM decrease in treated patients as compared to placebo. Importantly, liver stiffness change were associated with fibrosis change based on paired liver biopsy. However, this is true, of course, at the group level, but whether this is true at the individual level remains to be demonstrated. Now, regarding MRE, we have a study, single center study, showing that a 30% relative decline in MRI-PDFF was associated with fibrosis regression. And regarding trials, we just have this single study, phase 2 with selonsertib, small populations, 54 NASH F2, F3 patients with spare liver biopsy, 24 weeks, and there was no significant relationship between liver stiffness change and fibrosis improvement. So just to recapitulate between the advantages and disadvantages between VCTE and MRE, the accuracy of MRE outperformed that of VCTE. However, the evidence is based on a lower number of patients. Availability is limited in MRE as compared with VCTE, which is widespread. Range is narrower, and we don't know about the limitation in patients with BMI above 40. Now, what about spontaneous short-term viability of repeated LSM? This is a critical issue, of course, if we're going to use it in trials. This is a retrospective single-center study, and as you can see, this is in chronic liver disease patients, mostly viral hepatitis. And you can see that over the whole spectrum of liver stiffness value, there was variation above 20% in half of the patients, above 30% in 1/3 of patients, and above 50% in around 10% of patients. Interestingly, the predictors were different operator and unexperienced. The quality criteria, IQR on medium ratio above 30%, liver stiffness value above 7 kilopascal at first measurement, BMI changes, and doubling of ALT. In line with this is a study about NAFLD patients with 2 liver stiffness measurement before liver biopsy within an interval of 6 months. Those with LSM below 8 kilopascal had no change, whereas those with elevated baseline LSM, 1/3 had normal result on second examination with no mild fibrosis on liver biopsies, suggesting false positive result. So this has to be taken into account. So how can we tackle this issue in future clinical trials? First, I think we should define standardized criteria to mitigate LSM variability, the so-called TOP criteria related to technique, operator, and patients. For instance, use the same probe, Excel probe, pay attention to the quality criteria, use the same operator, experience, and take into account patient criteria as well. What magnitude of LSM decrease is relevant? 20%, 25%, 30%? There is no consensus. Now, I would like to bring some data in favor of using a 30% LSM decrease to define response. These are unpublished data from a very large international multi-center cohort, including almost 11,000 NAFLD patients with 2 VCTE that is run by Vincent Wong in Hong Kong, who I would like to thank for allowing me to present this data. You can see on this figure the risk of liver-related event according to change in liver stiffness. And if you have a 30% increase, this results in an increase in the incidence of liver event with a hazard ratio of 1.2. Interestingly, if you have a decrease of 30%, this results in a decrease in liver-related event of a greater magnitude with a hazard ratio of 0.6. This very important data will be published soon, hopefully. Now, another way of looking at this is looking at the incidence of liver-related events according to the baseline liver stiffness value. If you're in the high-risk group and you have an increase in 30%, you have a 56 incidence that is higher than those with stable liver stiffness. On the opposite, if you have a decrease by 30%, you have an incidence of 16, lower than in the stable group. The same holds true for patients in the intermediate risk, and finally you go from less than 1% to 56%. These data are very important and will be published soon, hopefully. Last but not least, combining ImagineNIT with serum biomarker can be used to improve the accuracy of response when the results are concordant between unrelated NIT such as liver stiffness, F, and PRO-C3, as illustrated in the efruxifermin study. There are many unanswered questions yet. Can liver stiffness decrease be used to predict response at individual level? What is the most appropriate time point? Do the mechanism of action and efficacy of studied drug have an impact on the percentage of LSM decrease? These are my take-home messages. Many patients who would qualify for treatment are currently missed in NASH trials because of limitation of histologic scoring system, especially ballooning. With the risk of approval of a drug that only works in a super-selected population, not representative of the overall patient population who would benefit from treatment. ImagineNIT are accurate in predicting liver-related events and can reasonably perform in place of liver biopsy for this purpose. Although regulators still require serial liver biopsy to determine treatment response in phase 2b and 3 clinical trial in NASH, this notion should be revisited with emerging data on the prognostic implication of NIT response. Important also to consider availability of approved NIT so that they can be used in real-world setting when the drugs come to the market. Thank you very much for your attention.
Hi, I'd like to thank the FDA for the invitation to speak about what the VA has done to take NITs from theoretical to practical, particularly when we had to decide who would be appropriate for treatment and to monitor treatment response. I wanted to talk about some of the decisions we made and a lot of the unanswered questions. Can I have the next slide, please? So these are my disclosures, and my presentation represents my opinions and not the opinions of the VA hospital or the VA system. Next slide. Oh, okay, so I would like to talk a little bit about what the VA population is and some of the decisions that we made when we developed the NAFLD treatment considerations, and some unanswered questions and some future thoughts. Next slide. So this slide has two figures on it. On the left side, the y-axis is in millions of patients. And the first bar shows that the VA has seen about 9.5 million patients over the last 3 years. And of those approximately 9.5 million, about 4.1 million have risk factors for NAFLD, defined as diabetes, prediabetes, obesity, or dyslipidemia. And if you look at the bar next to that, most of those patients have an ALT less than 40, about 15% have an ALT over 40, and in the bright red thin bar at the top, those are the people that have actually been diagnosed with NAFLD. So the VA, probably like many other healthcare systems, has a large number of people at risk, and only a few of whom have been diagnosed, and many of whom have normal ALTs. If you look at the two bars on the right, those are for all the 4.16 million people, and in a bar in blue shows that about half the people have a FIB4 less than 1.3, and the bars on the right show that about 15% of the people have been seen by gastroenterologists, and 85% of the people have not been seen by a gastroenterologist and are either in primary care or don't have a doctor assigned to them. And basically, there are not enough gastroenterologists in the VA system to manage all the patients with NAFLD or NAFLD risk factors. So these patients are going to have to be managed in primary care. Next slide. So the VA realized that NAFLD was a considerable problem, and they started thinking about guidelines for the recommendations for treatment, evaluation and treatment around 2019, maybe 2018. So that was 4 or 5 years ago. And we worked on the guidelines on diagnosis and treatment, essentially without input from the AASLD, the AGA. And so many of these recommendations you'll see after this are similar to the AGA and AASLD recommendations. However, they were developed independently and prior to the publications of either the AGA or the AASLD. The rule that we generally have is that whatever recommendations we make have to be available to all veterans and available to all providers. And when you look at all providers within the VA system, and when you look across the VA, there are a lot of variables. There are some very large VAs, like in Los Angeles and Houston and New York, but there are many, many, many smaller VA facilities at places that many of us have never been to. Santa Fe, Fargo, North Dakota, Chillicothe, Ohio, Altoona, Pennsylvania, and many other small places. The expertise varies from having a hepatology expert to having just primary care. And the same goes for radiology, pathology, and surgery. It's available at some places, but many places just have primary care. And I would say that, it goes rural and urban, and socioeconomic status is overrepresented in the VA system. The next slide. So when we started looking at this, we used we thought about the quote old diagnosis that if you drank alcohol, you couldn't have NAFLD. And we adopted the then new diagnostic algorithm shown here, saying that if you have hepatic steatosis and risk factors for NAFLD, then you should be considered to have NAFLD. And you can have other risk factors such as hepatitis C or hepatitis B or alcohol. So it was a very broad definition of NAFLD. We're in the process of looking at our recommendations again, and we'll probably adapt the new AASLD EASL recommendations for the diagnosis of NAFLD. Next slide. So one of the first things you have to do is kind of risk stratify patients. And we had multiple discussions about how we should risk stratify people based on biochemical or blood tests. And we essentially decided that standard blood tests we've talked about before today and shown here, such as FIB4, were really pretty good at excluding advanced fibrosis, although they had a poor positive predicted diagnosis for F2 fibrosis, and they don't appear to, that proprietary blood tests don't appear to offer any significant advantages, although they're a lot more expensive. And so we had the algorithm down below that I think is now commonly used and recommended by many people. It was recommended at that time too, that if your FIB4 is less than 1.3, you're managed in primary care. If it's greater than 2.67, you are referred to GI, and the intermediate group needs further evaluation. Next slide. So one of the things that we had to think about was how do you diagnose NASH non-invasively? And we suggested basically some liver stiffness test. More typically, it's VCTE. Some people have MR elastography, but it's not widely available in the VA system. And our general decision was if you're less than F2, then we're going to call it either simple steatosis or NASH with minimal fibrosis. But if these tests are consistent with greater than or equal to F2, then more or less by definition, we called it NASH. Next slide. But I think there's still a lot of unanswered questions and data that we need. And one of them is, and many of these issues have been discussed yesterday and today, but we would like to have a blood test to diagnose MASH in a population with risk factors, such as prediabetes or obesity. Will the NIMBLE or litmus or metabolomics be applicable in a low-risk population? Will new blood-based NITs be more useful than ALT in predicting the risk of cirrhosis among patients with risk factors? And will genetics help us at all in predicting the risk of cirrhosis among patients with risk factors? Next slide. So then we sort of looked at, well, how are we going to really diagnose MASH for indication for treatment? And liver biopsy was excluded for many reasons that have been discussed here before. MRE was not available and really had to be excluded. And the most available test was VCTE, which was non-invasive and acceptable to patients. However, there are limitations in VCTE, and I think we've discussed many of them here today. One of them is availability, and you see this map from EchoSens. And there's quite a few blue dots, which is where FibroScan machines are. But even if there's a blue dot, it doesn't mean that the patient from the VA can go in there and get the exam. So the availability of FibroScans is problematic. We also have reliability, repeatability, and some problems that were discussed a minute ago with BMI greater than 40. Next slide. Next slide. Let's see what we got. Sorry. Okay. One slide was changed. So some of the key questions are, what is the positive predictive value and the negative predictive value of VCTE or any other fibrosis NIT in diagnosing greater than F2 in populations with a low fibrosis? Or what's the prevalence of greater than F2 among patients with risk factors and intermediate FIB4 and elevated ALT? So we can find those patients, but we still don't really know what the how you can really pin down greater than F2. How do the newer VCTE and other tests such as ultrasound Velicore compare with FibroScan for the diagnosis and reproducibility, and that can they be used in prediction scores that have been developed for FibroScan? What's the repeatability of VCTE in real world settings, especially among patients with KPA of 8 to 10? The slide before that was different on mine showed that about 25% of the people that had a VCTE FibroScan stiffness of greater than 8 on a repeat exam by another examiner had a FibroScan of less than 6. And I think Laurent also showed some issues with repeatability of VCTE. Another question is, what non-invasive tests should be recommended to diagnose MASH and or stage fibrosis in lower resourced or rural clinics that don't have the facilities of large hospitals? I think a question is F2 really required to prescribe pharmacotherapy for MASH? What are we trying to prevent, and what are the criteria for treatment? And I think we've heard several speakers this morning say that liver biopsy and the diagnosis of MASH is not always that good for finding people who might benefit from treatment. Next slide. In terms of, again, my slide is a little bit different. Response to pharmacotherapy. For vitamin, we recommended 2 treatments, vitamin E and pioglitazone. And our recommended treatment, monitoring response, was that we would assess decrease in ALT by 20% or more. This took a lot of discussion because we wanted a non-invasive assessment, and ALT had been used in other studies to show response to treatment. Next slide. Yeah. Okay. ALT, again, has been shown to predict liver-related mortality in the US. It's been used in other diseases to identify higher risk for response to treatment or identification for who should be treated. It's used in prognostic scores. and it's correlated with improvement in histology in autoimmune liver disease and Hep B, and in controlling of an underlying disease in Hep C or alcohol or Hep B is associated with an improvement in ALT. And in NASH studies in PIVOT and FLINT, reductions of a certain amount of ALT was associated with histologic improvement. And it's inexpensive and available anywhere and understood by clinicians. So it was generally thought to be a potentially useful drug to monitor response to treatment. Next slide. Next slide after that. So some of the unanswered questions are, is ALT improvement an appropriate NIT for response to treatment, especially for an expensive medication? What NIT is best to assess non-response? We prefer a blood test, but we have to think about reproducibility, availability, provider education, and population monitoring. Should treatment be extended if a non-invasive test improves, but not to the desired level? And in a sense, what is the appropriate endpoint for treatment? Is it NASH resolution, progression to cirrhosis, or clinical outcomes? Next slide. Thoughts for the future. We do need a blood test to diagnose MASH. We need a test to diagnose greater than or equal to F2. And until we have better tests, what NIT should we use to diagnose MASH and stage fibrosis among patients with risk factors? NASH pharmacotherapy is likely to be expensive. We may need multidisciplinary clinics to manage NAFLD. Pharmacotherapy of weight loss needs to be thought about in people with NAFLD. And essentially, how will treatment of weight, such as GLP-1s, alter, and how can we monitor improvement in NAFLD and NASH in people that get GLP-1s to determine who might need therapy for NASH? And can data from the clinical trials be generalized to more generally across the VA system and in general use, given multiple comorbidities that are present in the general population? Next slide. We expect pharmacotherapy to be approved in 2024, 2025. It's very likely to be costly to large healthcare systems. Routine liver biopsy is not an option, and we need to have better NITs that are widely available to allow us to diagnose NASH. And the problem we're dealing with right now is that we need to make decisions on who's a treatment candidate and on response and non-response with limited data and limited NITs. Thanks for your attention.
Hi, everyone. Welcome to this last panel discussion. Let me start off by congratulating Ruby and Abbas and all the FDA team for a wonderful, exceptional 2-day workshop. We have learned so much. We really appreciate all the work you put into this to make this happen, and it is just absolutely so timely. My name is Veronica Miller, and it is my honor and pleasure to moderate this panel together with Frank Anania, whom you've already met several times. I am the director of the Forum for Collaborative Research and also a professor in public health at the University of California, Berkeley. And in my early years, I was an immunologist.
That look all right? Perfect.
Can you hear me?
Yes, we can.
Good. In my early years, I was an immunologist doing bench science as well as in the early HIV days, but transitioned to HIV clinical research, which is what got me so interested in Innovation in clinical trial design, the use of novel biomarkers such as viral load, which was one of the early surrogate endpoints ever used, but also the importance of data and the difference of data coming from RCTs and real-world data sources. All of that left an impact on me, so it was a real pleasure to come to the forum and continue that line of thinking here. So in terms of conflicts, the forum overall is funded by many different companies, both pharmaceutical and diagnostics. They're all listed on our website. And I've done a little bit of ad hoc consulting on an ad hoc basis for Merck, Intercept, and GSK. One thing we have certainly learned throughout these last 2 days, and we discussed this also in Paris at the Liver Forum there, is the incredible amount of infrastructure, resources, and commitment it takes to make progress in a field like this. None of this happens because of, people spending an afternoon on a Sunday doing a little bit of work in the lab. This is really, really intensive and requires good infrastructure, commitment, and also especially the commitment for the long run, because it's we just have these large data sets and these collaborations that are needed to resolve some of the questions in this field. So we have a bunch of questions, but let me start off with the first one. And oh no, actually before that, I will ask those panelists who have not yet spoken to make a few comments to begin with. So Professor Ratsu, I will start with you. Please introduce yourself and present some comments to get the conversation started, please.
Thank you for the invitation to be part of this workshop, which is very timely. I very much enjoyed the presentations. I look forward to seeing all the other sessions on the YouTube channel. Clearly, we're reaching a tipping point in the way we do clinical trials, and I think that a lot has been said. I don't think I have anything to add, I would say, analytically to what has been presented for the different NITs and the way they can predict the disease or outcomes. Just to start the conversation, maybe synthetically, I can make a proposal about how future trials should be performed in terms of assessing treatment response. So the overall structure of phase 2b trials is that they are performed on a smaller number of patients and a rather limited amount of time. And therefore, we need very powerful tools and very sensitive tools to detect a change. It becomes clear that traditional conventional pathology is no longer suitable for clinical trials in NASH for the reasons that have been shown extensively. And therefore, my proposal would be that for a phase 2b trial, where you need basically to understand the potential for an anti-fibrotic effect of a drug, what should be used is digital pathology helped by artificial intelligence, because using continuous score of fibrosis, because by doing that, we remove, we implement the automated aspect, the fully automated aspect of measuring something. We limit variability between readers, and we use a quantitative tool that is sensitive to change. So there are a lot of tools that are being developed right now, and hopefully will be qualified for use in this setting. So I think it is very important that when you do a short trial with small number of patients, you use something that's very sensitive to understand whether there's an anti-fibrotic effect. As far as NASH resolution, I'm a very strong believer in the fact that disease activity is what drives fibrogenesis. That has been extensively explained over the past 2 days. And this is an aspect that we need to measure, at least in the short term, because it gives you an understanding of how the drug works in terms of improving fibrosis, which is the ultimate endpoint. But in order to get there, you have to understand whether there's a direct effect, whether there's an indirect effect, how much of this is carried through an anti-inflammatory effect. So we cannot throw away the idea of measuring sort of the impact on the disease activity. Now, what has been shown is that the way we diagnose NASH resolution is largely suboptimal. And I think we should go back to an idea of measuring disease activity meaning essentially liver cell injury and inflammation. So phase 2b trials should be used as far as assessing efficacy, as far as fibrosis, digital pathology, as far as disease activity, probably traditional histology, since we're not there yet with digital pathology in terms of measuring disease activity. Moving on now to phase 3 trials. Here again, maybe a subset of patients could still use liver biopsy to see whether there is, to confirm the antifibrotic effect that has been previously shown in a shorter term trial, a small number of patients using maybe digital pathology, maybe conventional pathology. But the larger number of patients should be tested in order to understand drug response using a panel of biomarkers. So as this has been explained previously, one biomarker is not sufficient. We should decide on a panel of biomarkers. FibroScan is sort of a natural candidate with the problem that it is operator dependent. So I will not rely on a single biomarker. I would try to have operator independent biomarkers in the mix of biomarkers that we use. And here again, we're going to run into the problem of defining response. Is it 20%? Is it 30%? I think that for the moment, we have good data that shows that if you change category, meaning from low risk, middle risk, average risk, or high risk, changing category is correlated with outcomes, and therefore that could be a good outcome for these trials. And then, of course, progression to clinical outcomes should be something that should be tested in long-term trials. But I would say, if this setting of provisional approval and then definitive approval is still what will be used in the next few years, I would say provisional conditional approval based on a panel of biomarkers, and then including progression to fibrosis and changes in class, and then full approval based on clinical outcomes. So I think that could be a good compromise for the future, and I'm open to hear your thoughts on that.
Okay, thank you so much, Vlad. And Laura Lee Johnson, we've seen you before, but for this particular panel, would you introduce yourself and provide some opening remarks, please?
Sure, and thank you for having me today. I'm Dr. Laura Lee Johnson. I am the director of the Division of Biostatistics that supports the Division of Hepatology and Nutrition. And I think a key point is, where is there a balance of data and a mechanistic rationale? So I think several people have mentioned, and I agree, that not every biomarker should in the end have the same purpose. And so the community can and should matrix out what evidence is still needed. And people may not agree, but at least the information would be there, and then it's a little bit easier to fill in the gaps. So part of what we've done today, and we've also, and yesterday, and we've heard from other community groups, that this work is happening. But it's also important, and this was brought up, that realizing something is just good as an inclusion-exclusion criteria, and the data needed will be different than what is needed to support an endpoint, and that is okay. Okay. So we also have to think through any given therapeutics mechanism of action, right? So a surrogate for one drug or drug class might be validated, and it might not validate for a different drug class. Although there also could be a universal surrogate, one or a few. And so completed clinical benefit trials are going to give us a better idea of the magnitude that's needed and the stronger evidence in general, excuse me. I also want to remind folks that, similar to what we've heard related to the discussion of histology, you don't want a surrogate built on a surrogate, all right? So histology has not been validated, and it's proposed and used as a reasonably likely surrogate, but that also doesn't mean that you need to use it. But it's also that when you need and want to validate an NIT as an endpoint, the goal is clinical benefit. It's not matching to histology. And as the second speaker mentioned, I think it's important, like, are trials enrolling patients actually using these NITs? And are they following those patients all the way to the clinical outcomes while capturing the various NITs in a prospective manner? And we would really need this in the randomized clinical trials of therapeutics. You can get part of the way in prospective studies, but not all the way You've got to have those randomized therapeutic trials that are going on. So many have recognized the need to continue to evaluate clinical outcomes, even if NITs are used as a reasonably likely surrogate endpoint. And it's important for the community to emphasize this to industry and patients and to help address some of the challenges in completing these clinical benefit trials that we discussed yesterday in session 2. It's also vital, as Dr. Christy Chang discussed yesterday, that we remember the story of Makena and many other products, including several in oncology, that if a drug is approved under Subpart H and does not have a successful phase 4 outcomes trial, if the company doesn't do it, FDA will take action to take an ineffective drug off the market. Just because something has accelerated approval does not mean that it is going to be effective on the clinical endpoints. And that's something that as a patient, as a caregiver, not just as a regulator, that I want my doctors, and we heard this loud and clear from the gynecologic and the obstetrics community, we have to be clear, all of us at this meeting today have to be clear as we are communicating. FDA approval should mean something, and Subpart H is not let 1,000 flowers bloom. Now, I'm going to give some provocative points now. If millions of patients with NASH are going to be willing to enroll in trials without biopsy, then taking away the obstacle of biopsy should mean that y'all are able to enroll many more patients to capture both clinical and NIT outcomes. So remember, accelerated approval is not a required step. Now, I know a lot of folks want to be able to start selling their drug, but it's not required. So why not aim straight to traditional approval? Everything but biopsies in there, including you want in clinical benefit. No stopping until you get the clinical outcomes. You may want to build in interim sample size adjustments because I will say, as somebody who spent a couple of decades doing clinical research, planned event rates are never right. But adaptive designs can be used and they can be needed, not just for efficacy, but also for safety. So I think this is a really important element to consider. Will a change like this potentially allow y'all in this community to more quickly complete outcomes trials and to more quickly learn about these NITs? Now, again, that may depend on the therapeutic that's being studied and how many different trials are going to happen with how many different therapeutics, but also realizing that, not all drugs may impact the disease course closer to events. Maybe these are still going to be longer trials. But as a friend of mine who went to medical school in her 40s said, she's like, I'm still turning 50 one way or the other. So we heard a lot of people discussing current NITs for enrichment and enrollment. And if there's this great faith in the power of non-invasive tests to predict outcomes and the desire to build benefit, to build that evidence, you have to test more than if you knew what the measures were going to use. If we all knew the measures, you don't have to do as much work, but we don't know. We suspect, we want, and there's going to be a struggle to get validated surrogates since you actually also need the drugs to work convincingly, and you're going to need several clinical benefit trials, and a lot of other people have talked about those for the past 2 days. But if we're not moving down those paths together, and I've watched this in oncology, I've watched it in several other therapeutic areas, walking together helps lead to the answers fastest. And medicine and research aren't going to get there without that, or it's going to be luck and not drive. The therapeutic groups that move fastest share data and they work it out. And as a regulator, I can't force y'all to share data, at least not that I'm aware of, but the groups that have gotten together, whether it was pediatric oncology, which is far more rare and has far more problems than this community for non-cirrhotic NASH has. That's how they got there. But it also means that we have to be willing to give up our favorite babies when the evidence doesn't support it. And it also means, and you'll see this in oncology and plenty of other places, they keep clinical benefit outcomes in the trials many times. But the lack of consistency in testing NITs that I saw in one of the slides that the second speaker had in this session, I think that in many ways could be part of the major problems here. There can be a lot of reasons why you don't have those NITs in your trial. But I do think that you're going to need a concerted joint focus in order to be able to move all of this forward. So I'll stop there and look forward to our continued discussion. Thank you.
Yeah, so Laura, wow, you really got us off here on a very good start. Thank you so much. I think you helped us really clarify, because this has been a theme throughout, the time that I've been involved in this field, is this need to validate a new NIT or a combination NIT against the histology. And thank you for clarifying again that histology is a surrogate and we shouldn't validate another surrogate with a surrogate. So I think that's very helpful and can help streamline some of the efforts. Also, really helpful to hear your thoughts about how to move forward. Obviously, collaboration and data sharing is a huge part of this, but also the potential to really start using these NITs in a role other than as a secondary endpoint. But that will have to be exactly how to do that, while the accepted surrogate right now is histology. I guess will require some more discussion. But you got off to a very good start. And I have a few questions here that are on the list to ask the panelists. And again, in the context of what you already heard from Vlad and from Laura, the first question is, what are some of the knowledge gaps of the currently available NITs? Now, that's a very, very complex question, and maybe we can break it down a little bit in terms of context of use, diagnostic, prognostic versus treatment outcome. And how can we fill those gaps the most efficiently? So any panelist would like to tackle that one first? I see the hand up, the brave Mason.
I don't know if I'm brave, actually. I'm gonna just try what I can do best. Can you hear me?
Yeah.
So I think with this process, we have to, as everyone said, get together, be transparent, and forget about our biases. I'm biased. I see patients every day. I publish data. I think sometimes my data is the best. I should get out of that concept and see what it takes, especially with experiences like Dr. Johnson mentioned, which is experience in oncology and others. I just want to comment on something and get to the answer. I think everyone here agrees that we are not going for the clinical outcome studies because they take forever. And we cannot wait for these clinical outcomes forever, because we already have a lot of patients that it's the leading cause of transplant, it's the leading cause of HCC. And that's why actually the FDA themselves, they started with surrogate more than a decade ago, which is a histology. I think from NITs and my bias is that now we have probably good data showing that they correlate outcome. If I want to think about it like to close the gap or give more evidence, is probably a large study that is prospective, that includes multiple patients using NITs. This could be one of the solutions. Could be possible. But I also would like to have some clarity today or in the future on what is reasonably likely to the regulators, and we will try to achieve that if we did not achieve it yet. If we don't have a reasonably likely surrogate endpoints with NITs, why not? And what do I need to do? And what's the bar? Is randomized control trial? I keep hearing randomized control trial. Dr. Johnson mentioned we'll give a definitive answer. I don't think anyone disagree on that. But is our observational study enough, like what happened with hepatitis C? So those are the questions I think we need to discuss and answer to work together, as said, to get where we need to be.
Okay, thank you, Mazen. Arun, Dr. Sadyal.
Yeah, hi, thanks. I think to build on what Mazen just said, we need to think about how to define the population for study, which would include integration of both our diagnostic NIT data as well as our prognostic, because you want to identify a population that is likely to benefit from therapy. So that will require some integration of the diagnostic and the prognostic tools. And then over time, whether it is the same tools that are tested again and again, not necessarily so. And I think somebody made that point in one of the 5 talks, that it could be a different set of tools to actually measure change over time. Because if you just take something as simple and crude as the FIB-4, it was never designed to be a disease monitoring tool. And it's inappropriate because you can get rapid changes in AST, ALT that have nothing to do with measuring the fibrosis, which it's supposed to be. Something as we think about these monitoring tools is really how they fit into the causal pathway towards an outcome. Because we all agree that associations don't make a surrogate. And that's a really critical element. And as we think about what is reasonably acceptable and think about a panel of NITs to define that it's reasonably likely that the patient is actually on the right track and improving, it should capture different elements of the disease that are relevant for progression towards the outcome. So you need some activity measures and you need some measures of fibrosis progression. And maybe at some point, maybe quantitative liver function or some other things like that, which integrate a lot of these different kind of things to give a composite readout of what's going on. But they will all need to be validated first before they can be used as a surrogate. And I think I completely agree with Quentin that in the context of these big phase 3 trials, there should be a minimal set of, some of the leading NITs that meet some of these criteria that should be measured in all the trials so that we can start putting that data together to build the evidence base to support its use in a more general way. And one last comment is that we have to separate steatosis out a little bit, because for certain drugs, the MOA clearly is through reducing lipid load in the liver. And their demonstration of a decrease in lipid load of the liver is a critical part of us showing that the drug is doing what it's supposed to be doing. Whereas for some others, it may not be quite as relevant. So I think we have to be very MOA conscious when we think about the profile of NITs to monitor treatment, not necessarily to define the population to be studied, but together, I believe we do have enough evidence to be able to at least conceptualize such a paradigm today.
Good, and we have Quentin and Vlad, and then I'm actually going to switch to a different question that's very much related, but slightly different. So let's hear Quentin and Vlad, and then I'll switch, and Laura, I'll actually ask you to be the first one to comment on that one. So Quentin?
Yeah, absolutely. I mean, I think Dr. Johnson's points here went right to the heart of the debate, and I completely agree with Arun's comments on this. I guess fundamentally, it comes down to the question about the distinction between a reasonably likely surrogate and a generally accepted surrogate. Now, the evidence base in 2013 was sufficient for us to take forward histology as a reasonably likely surrogate. I would suggest, and I think through the work of Nimble, through the work of Litmus and others as well, that we probably have at least as good evidence for NITs now as we did for histology in 2013. And arguably, we have better evidence for NITs now than we do for histology now. So I guess my question is, of course, we don't have the data yet for full surrogacy, for generally accepted surrogacy. But I think with that safety net of outcomes within those phase 3-4 trials, like the ones that are currently running, I believe that we probably are at the point where we could start using NITs there with a degree of confidence, and that would help us to build the data in a what I would perceive to be a very safe space. It'd be interesting to hear other people's comments, but I think that's, if you like, the sweet point between having to be safe, which of course we do. And I think that phrase, we don't want 1,000 flowers to bloom. I think that was a wonderful way of putting it. We certainly don't want that. But equally, we don't want people missing an opportunity for treatment because we are tying ourselves to a reasonably likely surrogate that is actually, we now realize, a failing or an imperfect surrogate. And so I think that that's why this is a very timely conversation.
Thank you. Flat, some brief comments from you so we can move on to the next question.
Yes, practically speaking, it will take a long time before we produce the data that will make us all agree that X% change in a particular NIT, whether going up or going down, is predictive of outcomes. The question then becomes the following. Based on what Quentin just said, which is that we already have a large amount of data showing that we can risk stratify based on any of these NITs, actually can risk stratify your risk of having clinical outcomes. You can be in the low category, you can be in the medium risk category, you can be in the high risk category. Since we do have that profusely for almost all of them, why, and this is almost a methodological question, why can't we consider in assessing the efficacy of a drug in a clinical trial that a change in the risk category on FibroScan or whatever, whichever biomarker you want, say from high risk to medium or from medium to low, why would, knowing that these risk categories correlate with outcomes, why would not that be a good indicator of the clinical effect of a drug without having to go into the percentage of change and relative or absolute change? In the end, what we're doing with histology is exactly that. Histology is a semi-quantitative spectrum. It goes from 0 to 4, and switching from 4 to 3 or from 3 to 2 or 2 to 1 is exactly the same conceptually as switching from high risk to medium risk or to low risk in FibroScan or whatever other biomarker. So why would that not be today sufficient to confidently predict clinical efficacy?
Okay, Dr. Johnson, can we put you on the spot?
You can try. Sure. Do you want me to address what they were just?
Well, I was going to give you the opportunity to address that, or maybe also weave in the next question, which is so related to this, and it has to do with uncertainty. So reasonably likely always implies that there's a level of uncertainty that still remains. And how do we deal with these uncertainties, especially when we probably will need to combine the different NITs and they each come with their own level of uncertainty? We've heard of convergence of data yesterday early on, and I think it was Peter Stein who talked about the importance of convergence of data. We've heard today about the importance of looking at patient-level data. So if in one patient, all of these points converge to improvement. So to what extent do these uncertainties multiply each other, or to what extent do the certainties that each one brings improve the certainty of what we're doing? But also then talking about sort of this issue of this categorical change, you know, from a statistical perspective, how would that work? So
All right.
It's loaded.
And I may not hit all of it, so we may have to circle this a few times. So observational trials can get you part way, but I think what's really important, I was trying to take notes here as you were chatting or going through the discussion here. You know, a lot of this NIT evidence ties to the histology. In fact, actually, most of it, if I'm remembering all these talks correctly, is really assessing fibrosis. And so I do think that there may not be as much evidence to get all the way through as folks in this session and this panel may believe. So it's really important to think through, correlation is not enough. Okay. Correlation does not predict a clinical outcome. It doesn't get you all the way to also, I remember as multiple people said, including my colleague, Dr. Rebecca Hager, prediction and prognosis are two different things. And correlation's even kind of lesser. So correlation might get you to a candidate, but it's not going to get you all the way to reasonably likely. And there's also, as you're building into this, of thinking about those strong mechanistic rationales. And so as you're saying, like, okay, the increasing fibrosis gets you to the more advanced clinical outcomes, as you're moving through, but still, like, categories all the time. And I think this was brought up even as you were talking about, like, why histology wasn't great. Like, categories are not miracle workers either, right? You've got to have a lot of intra and intra-rater reliability information as you are moving forward. And also sometimes, like, you have to throw something out as something to look at, and then you say, well, we're not there. And so histology was well described and discussed and thought through, but it was also a stepping stone. It didn't say this is a validated surrogate, said, here's a stone that we think we can stand on, but it may not be the stone for you. That guidance does leave open that there are other ways to think about this. And as I mentioned, like, you could just go all the way to clinical benefit there. But if somebody brought forward that strong evidence base, but that evidence base that was there for histology is not fully what's presented for these other NITs. And part of that is, I think, because of that emphasis that has happened, thinking about histology as what you're going against, because it's that shorter term idea. But I think we still have to consider how much change. So let's say you find something, you find some categorization that in fact everybody is actually, your inter and intra-rater reliability looks good. I can use this in all different patient populations around the world. And so whether I'm in Fargo, North Dakota, or Houston, or in Paris, I can still get this assessment done. So we've come up with our favorite set of NITs or favorite NIT. We still need to understand that disease activity, that disease progression, that information will still need to be there. And so it doesn't get you to a faster end of all clinical trials up front. And I hear and I understand people wanting that. That's not how the science works. And that's the reason we all have to work together to scientifically move the path forward. So I hope I hit on all the notes that I had down here, but I may not have, and I'm sure Frank or somebody else will pick up.
Right. If I can just probe you a little bit more there on this issue of converging direction of change within one patient. So we have patients who respond, patients who don't respond. But if in some patients we see that there is a convergence of data going in the same direction towards improvement, to what extent does that then validate, and I'm using the word in quotation marks because validation has a very strong meaning here, but validate that whatever this drug is doing is resulting in an improvement that can be measured in many different ways. And all of these different ways converge, within one patient.
So I think part of what's also important here is that one patient is different than understanding how everything is converging now for 100 patients, 1,000 patients, et cetera. And this is where, and I think it's wonderful and good as somebody who's trained clinical investigators for years, it's important to have both hats. But in the clinic, and actually that's what I meant to come back to, is the algorithms, because the algorithm in and of itself becomes its own biomarker, right? And when you're combining them all together, and we call it, and we have a guidance on multiple endpoints, and so we'll call it a multi-component endpoint. And that in and of itself has to be tested. Now, it might be that actually combining multiple things together, but again, it's the algorithm to do that. And I can't go inside of all of y'all's individual brains and piece out like, okay, this is exactly how they're weighing things. Although there are groups, and I believe someone talked about this in a session, and I know that we've done it in infectious disease, where basically, and I want to say, I won't name it because I'm afraid I'll get it wrong, but they actually went through and they said, here are the patient vignettes, and they sent it to this large group of clinicians. And this was at an NHLBI presentation yesterday, actually. And they gave this to everybody, and they said, you tell us what you think the diagnosis is and where you would rank them in severity, and tell us why. Like, just give us a paragraph back. Explain this to us. And they now are harvesting that information. So it's kind of a crude form of qualitative and mixed methods approaches, but they're using that information to try to take a first stab at an algorithm. And then they're going to process through, and they have a much longer research line that'll include bookmarking and a variety of different things. But in order to come up with an algorithm using these different elements, and then that is going to be what they send through that whole kind of testing paradigm to make a decision. Hey, is this something that we could use as a reasonably likely surrogate, and maybe eventually as a validated one?
Right.
So I say all this because I think as an individual MD sitting in front of the patient, you will take all of your collective wisdom and make a call. But when we're trying to do this otherwise, I think we have to take a step back, and it is a different part. Now, Frank's had his hand up for a long time, and
I know
he's the acting division director, so I think it'd be great to.
Yeah,
I absolutely.
And he may have something different to say.
Well, I wanted to, first of all, thank folks, but I want to go and hit the ball way out in left field. Because we didn't discuss this, but I want those of you who are vested in NIT development to understand that in the year 2022, the U.S. government passed a law that amends the Food, Drug, and Cosmetic Act. And in that law, we're going to require industry to provide not only safety, but also data of effectiveness that is representative of the U.S. population. And when I hear first from I brought this question up because I thanked Dr. Morgan, and we included him as a fellow federal physician, who mentioned to all of us about the income inequality and disparities that exist in this field. Okay, that is something as a public health steward, I also has not been brought up in this meeting, but I feel it's very important for you all to hear. And I commend Dr. Morgan because, as you heard, they don't have the resources. And one of the things I was going to ask Dr. Ansley and Professor Castera, if there are data from the European Union and internationally outside of the United States could be applicable in understanding the use of NITs for the population in which Dr. Lee and I, Johnson, regulate these products. Because ultimately, not only we discuss duration of time, but the industry has been very responsive because they're going to get incentives. So they're already sending their plans in, and we haven't even formalized this pathway yet of studying patients in the United States. So how should we use those data from countries outside the United States? And we'll ask Professor Ansley first, and then Professor Castera. I'd like to hear what their thoughts are about that.
Yeah, so I think that's a really interesting point. I think fundamentally what you're dealing with is actually that there is a great deal of similarity. So if you think about the Veterans Administration, from my understanding, it's a relatively resource-constrained environment, and there's the need to deliver care in a cost-effective way, which is targeted and does the greatest good for the amount of money available. That's actually incredibly similar to the situation in most socialized healthcare systems in Europe, so the NHS and so on. So the populations we're recruiting in Europe actually probably resemble in most ways the VA experiences very closely in that way, possibly more so than the highly insured end of the spectrum. So At that point, I think that there's a degree of confidence we can have. The second question comes down to the biology of it. And of course, the biology is the same, if you're Homo sapiens, with some degree of clarification, the biology is the same here. So I think when we're talking about whether data is transferable from one country to another, I don't think we've got any reason to suppose it isn't. And in fact, what we need to see is consistent data. It would be more worrying to me if Nimble had a positive result and Litmus had a negative result. What I'd like to see is both of them, agreeing with each other, and potentially in other parts of the world as well. So I actually think that the diversity that these different consortia bring is a strength. And I think that there is much in common, although we choose not to believe it, between the healthcare systems we all operate in.
Thanks. And Dr. Castera.
So I think this is a very important point, and I would echo what Quentin had just mentioned. Maybe to be more practical so far, because I think we need to dig into data. And clearly among NITs, liver stiffness using VCT, this is the NIT where we have more data, and it is already widely used in clinical practice. Now, if we look at the different countries, not only US, Europe, but Asia, as I mentioned, BMI is really an issue in terms of viability and also reliability. And of course, the proportion of patients with BMI above 40 is much higher in the US than in Europe and even in Asia. And we don't really have comparison of all this data. But then if you end up with an NIT that has different performance in different populations, that may be an issue, a practical issue. Are you going to use it? And we definitely need more data. Also, I mentioned something that is very important is the variability. And I was quite surprised when I look at the literature, there is so little literature, actually a single paper addressing this. This is urgent. We need this data. This is easy to, this is a low-hanging fruit. We can easily get this data from the ongoing trials. We need this data desperately. This is very important, in my opinion.
I'd like to add, thank you. Dr. Morgan, I'd like you to comment. We haven't heard from you, and I'd like you to give a chance to speak.
Well, thank you. My biggest issue, I think, between the NHS and France and the United States is African-American population, sort of ancestry. I think the Caucasian background is probably similar. Most of the Caucasians are, Western Europeans. But I think that not so many Hispanics and not so many African Americans from Europe. But I think by and large, a lot of the data from Europe would be transferable to the United States.
Thank you. I want to move on to another question. Sorry, Dr. Sanyal and Nareda. I'm going to call on you for the next question that I have. So one of the things that's been discussed at this meeting was artificial intelligence and machine learning. And Professor Retsui had mentioned the use of that as a means to expedite the therapies to marketplace. Dr. Miller, actually, before the conference convened, and several other patient advocacy groups had written to me, some of them pretty obstreperously, about why they were not included in this two-day forum. And it was my opinion, as I told Dr. Miller and others, that I would try my best to represent them at this meeting, and that we had so much science to go over. And as you see, we're coming to the end of 2 days, and we haven't resolved a lot, but we certainly learned a lot from each other. But nonetheless, I have a question for Dr. Sanyal and then Dr. Nareda to follow is, how do we reconcile that there is, as Dr. Retsui and Dr. Friedman yesterday talked about the promise of AI, which there is, and machine learning, and the fact that we know that the pathologists had trouble in that one landmark article about ballooning degeneration. How do we reconcile that with the patients and the stakeholders who come to me and say, Frank, Nobody wants to have a liver biopsy. I just want you to comment on that because I was left yesterday. I heard one of the pathologists talk about the beauty of this tool, of course, for diagnosing tumors, which I would agree with. But I wanted to hear from some of you who are interested in alternatives to histology, what your take is on AI and machine learning, because we consider that also a biomarker, a surrogate. And I will start with Professor Sanyal, and then I want to ask Dr. Morin, and then finally Dr. Ritsui to come back with a comment. Thank you.
So Frank, thank you for the question. I view this as part of our armamentarium and not as sort of a replacement of, a tool and be a standalone thing by itself. So in early phase trials where we have short duration, small numbers of patients, it takes a big effect size to move the needle on conventional fibrosis stage, which captures both the distribution and the amount of fibrosis. Circulating biomarkers, they give us an overall sense of the total fibrosis burden or fibrogenesis, but not necessarily changes in distribution, etc. So in the short term, the AI, where the current data sets, gives us a way to identify changes that may not otherwise be captured by the classical NASH CRN or even the SAF scoring systems. Furthermore, it allows us to capture changes in multiple dimensions. So what I mean by that is that you can see changes in parameters linked to fibrosis in periportal areas, centrizonal areas, perivenular areas in the septa, all separately. And there's a whole emerging field about reclassifying how fibrosis evolves and resolves in NASH, learning from hepatitis B and other states where there are characteristics of progressive septa versus regressive septa. And certainly with Tropifexor trial, we were able to see changes using some of these parameters that were not obvious with conventional histologic staging. The key issue then becomes, do those changes really reflect a likelihood that in the long term, you will have less progression to cirrhosis? I think we will need more data for that. So I'll stop there and let others weigh in.
Thank you. And Professor Noureddin.
I'm just going to build on the same what Dr. Sanyal said, but I'll go with patient's example, and I want to assure them that we're all sides are invested in their best interest. But I will go back to that. I want to answer the machine learning with the patients that I presented earlier that are excluded from clinical trial. I think it's clear today that the same people who implemented NASH resolution and ballooning as a surrogate biomarker a decade ago, now after doing research, and that's what we do in medicine, we do have a problem with the ballooning. And that's a great example for machine learning. That patient was excluded, although the local reading said, oh, he's otherwise included. He's an F3 patient. What do I do with such a patient on the long term? We know weight loss and exercise doesn't work all the time. So the people are trying to push the envelope not to lose such a patient, and especially in the controversial area. And I consider that ballooning cell controversial now at least, and we need to resolve it. Is the question, we go back to 2 points NASH improvement? It could be. That's something we need to discuss. Along the same line of what Dr. Sanyal said, I will remind you, multiple people, Dr. Rocky, Dr. Friedman, in this workshop, they said, I don't need necessarily the patient to improve. We all know the concept now. Well, we're sure we need them improve, but we know the concept now. If you can hold the cirrhosis for a very long time or do even tiny changes, we can get better. And F3 to F2 is not like F4, F3. So that's where we're talking about machine learning. If I can go from F4 to 3.75, I just made that up, although there's literature on that, that's a win. And the current system does not allow us to do that.
Thank you. Professor Ratsu. Any final comments? I want to go with one more question. We're going to have about 9 minutes left. So I want to go one final question that this leads into this. Do you have any comments, Professor Ratsu? Follow up.
Yes. So your question, Frank, was.
Well, I think that we talk about tensions between, not doing biopsy for all the reasons that we've discussed at this meeting, and yet the promise of AI. You mentioned it yourself. I mean, how do you reconcile that with patients and other stakeholders who are not wild, obviously, about doing liver biopsy? And I have a follow-up question I want to get to that I'm going to go around and ask you all. But if you have any comments about this, if you don't, that's fine. I'll move on to my next question.
I have a short comment on that. It is clear that digital pathology holds great promise, and Arun explained very well that it provides a better understanding of the kinetics of fibrosis changes, both ways, regression and progression. After all, these fibrosis stages, whether METAVIR or NASH-CRN, they're very skewed in favor of architectural distortion rather than the amount of collagen. And what you want to understand in the beginning is not just that sort of surrogate of fibrosis, of extracellular matrix deposition, but rather a finer understanding, more subtle understanding of the ins and outs of how fibrosis progresses, regresses, the quantity of fibrosis, the type of fibers, and so on. And of course, that is useful in the beginning of a trial when you investigate the potential of a product. It's not so much useful for large phase 3 trials where you have to show clinical benefit. So, but great potential for digital pathology. But in order to do that, you need to do a liver biopsy.
Oh,
You're
yeah.
saying that a lot of people are not happy with liver biopsy. Well, you have seen at the division now phase 3 trials on thousands of patients that had 1, 2, or 3 liver biopsies performed. It is possible to get those liver biopsies done. It is possible to convince the patients that it is important because people desperately need drugs for this condition.
Okay.
The way I'm ending just by saying that the way I outlined that in the beginning, saying that phase 3 trials should probably be performed with a mix of biomarkers rather than relying on histology, makes it that we will save a lot of these biopsies in the future if we adopt a paradigm where biopsy would only be restricted to early phase trials for the reasons we've seen, but not for phase 3 trials. So it's already a big step forward by saving all these biopsies.
All right. So my final question, thank you, Dr. Red. So one more question, just briefly. So we've heard a lot at this meeting about NIT. Certainly, I've learned quite a bit. I guess one of my questions that you can all put a regulator hat on, and Dr. Laura Lee Johnson and I will sit back and listen. Our draft guidance compared to the European Union, I don't know what the Brits do now because I know that they're separate, but we have these 2 endpoints that we've established, as you all know. And I guess one of my conclusions would be from all of you, you can play the regulator. If we dumped the no reduction in the NIS score and just focused on fibrosis, since the vast majority of what has been presented to me, at least, maybe I'm wrong, in the past 2 days, has been squarely focused on fibrosis. And as you all know, someone who studied fibrosis in the laboratory for 20 years, it's near and dear to my heart. But now I'm a regulator. So you be the regulator and you tell me, Frank, it's okay if you and the EMA dump the inflammation, and we'll worry about that because we're just going to look at fibrosis. Because to me, it seems that the NITs that have the most robust data, Quentin and Arun, are those that really squarely focus on the fibrotic response of the disease. So I want you to answer, and I want to let Dr. Ansley talk first because he hasn't spoken about, and then Dr. Sanyal, because we'll have to wrap it up. But I really want to thank you. These questions have been on my mind. They're sort of out in left field, but I wanted to bring them up. Thank you.
No, I think this is an important point, and it's undoubtedly true that in terms of NITs, the strongest NITs we have are for fibrosis. However, the key thing to remember with NITs is that you have collinearity between the inflammatory processes, in other words, the steatohepatitic processes, and the fibrosis processes. And that is the case even, if you think about histology, it's very seldom you see an active progressive fibrosis without the presence of steatohepatitis. The same carries through into NITs and so on. I think it is right that we should be focusing on fibrosis because it's actually the thing that we know is the closest to hard endpoints. But, and this is the key thing, Frank, here, this is the area where MOAs begin to come into the discussion because there will be some anti-metabolic drugs that work a long way upstream. And so they would take an unmanageable amount of time to read through into a fibrotic change. So I think here you've got to tease this one apart. I completely agree. There isn't an easy answer.
Yeah.
But
short answers.
but what are the solutions? Well, the solutions are, if we're going to stick with histology, we need to move away from ballooning yes, no, and consider it a quantitative change. AI approaches can help us do that. So that's the first thing. The second thing is we need to cross-validate. And with that Venn diagram I showed you, 2 of those as a minimum should be NITs. You can consider whether the third one is an AI-assisted histology or not. But as a minimum, 2 of those 3 circles should be NITs, would be my suggestion. And that gives, with my regulator chapeau on, that gives you the degree of security.
Thank you, Professor. Dr. Sanyal, your thought.
Very quickly, in the interest of time, I agree with what Quentin said and would like to reiterate the issue of mechanism of action of the drug. So if a drug works primarily by reducing activity, you should include a measure of improvement of activity. And it may be that you have to use a combination of biomarkers to holistically assess that. And to the extent that we can use biomarkers that are multimodality, like one, for example, measuring stiffness, and another one measuring a biochemical measure of injury, etc. Since none of them are perfect, it'll give you a better idea it'll make you more reasonably certain that this will translate into something beneficial.
Thank you, Dr. Sanyal and Dr. Naredin, and we'll get to everyone else. Yeah.
Sure, I'll do it quick. I think we don't want to remove the disease activity per se. Our issue, I think, is with the NASH resolution and the data that has shown it has caused problems. To quick answer, if we would stick to histology, I would keep the fibrosis improvement, as you said, and personally, I would rediscuss 2-point SNAS improvement and address the weaknesses in ballooning. That can be done through new methods that innovative and measure tiny changes such as machine learning. Nevertheless, my last 30 seconds is, I think I do respect what you guys do. I thank you for doing this. I understand the responsibility, but we also would love to sit down and talk about what is reasonably likely to predict outcomes. We do personally think that NITs are there. We do also think the NITs can measure disease activity if you combine them. And I think this is the core of the discussion that we need to continue.
And thank you. And you have about 30 seconds each, Professor Ratsut.
Yes, Frank, I'm very happy you raised this point. As currently defined, the composite of NASH resolution without worsening of fibrosis makes sense, because we know that as people progress towards cirrhosis, the inflammatory activity might disappear and therefore might have less steatohepatitis activity. That makes sense. What, in my opinion, doesn't make sense, and I think it addresses your precise question, is the composite of fibrosis reduction without worsening of steatohepatitis. That doesn't make sense. It might theoretically fit with some drugs, but we never see that in the natural history of the disease. So I think clearly that if you keep the histological, based on conventional pathology, definition of this endpoint, you should get rid of that part of no worsening of steatohepatitis. So just fibrosis reduction, one stage, and that will help us make comparisons that are more valid between studies, because some people define NASH resolution in different ways, as you very well know. So that makes no biological sense to me, and I think we should get rid of that part of the definition.
Thank you. And finally, the last word from Paris, Professor Castera.
So in a nutshell, get away from ballooning, focus on improvement on fibrosis, use at least 2 unrelated NITs, and LSM should be at least one that should be used because we have the highest level of evidence.
And with that, I want to thank you all. Dr. Miller, you can conclude the meeting. I do want to thank you. These were very fun, provocative questions. So we appreciate your input.
Thank you very much to everyone for this wonderful panel discussion. Honored to co-chair that, co-moderate that with you, Frank. And we have lots to talk about as we move forward. And so hang in there, stay tuned. Thank you.
Good afternoon. I'm Ruby Mehta, Clinical Team Leader in the Division of Hepatology and Nutrition here at the FDA. On behalf of my colleagues in DHN, I want to thank all FDA members, our esteemed speakers, panelists and discussants, moderators, those participating virtually for making this workshop successful on non-invasive markers for metabolic-associated steatohepatitis, or MASH, a highly informative and thought-provoking workshop. The information that you have shared will be reviewed by the division as we continue to assess biomarkers for use as surrogate endpoints likely to predict clinical benefit for the treatment of MASH with fibrosis. Over the past 2 days, we have learned that knowledge gaps exist on several levels. As was pointed out yesterday, MASH, unlike viral hepatitis, does not have a single etiological agent driving the disease, and MASH behaves more like diabetes or hypertension, and patients will likely require lifelong therapy, or at least for prolonged duration. The ongoing unresolved questions concerning MASH and fibrosis, as discussed throughout the workshop, makes it more difficult to find appropriate biomarkers that are clearly on the causal pathway to MASH with fibrosis. Today we heard through the excellent reviews on potential imaging and circulating biomarkers that could be considered for clinical MASH trials as surrogate endpoints likely to predict clinical benefit. These are attractive insofar as they do not subject patients to undergo liver biopsy. However, we learned that to serve as a reasonably likely surrogate, epidemiological or mechanistic evidence is needed demonstrating the NITs are predictive of clinical benefit. And we cannot rely on validating the biomarker to liver histology, whether we are speaking of inflammation, ballooning, or fibrosis. That is, these should not be surrogates of surrogate. Clinical validation of any of these non-invasive biomarkers need assessment to clinical benefit and be demonstrated in clinical outcomes trial. Another question that was raised was, can there be universal surrogates? We also heard from Dr. Belling yesterday that NASH is not only 3 components, which is steatosis, inflammation, and ballooning, and that there are many features that are valuable to assess, such as portal inflammation, differential inflammation, and fibrosis. Using single or multiple non-invasive tests, we may miss having this useful information. And most NITs may not assess this differential inflammation and other features of NASH and different location of fibrosis, at least to inform the earlier trials demonstrating mechanism of action of drug. Because disease activity is the main driver, NITs assessing disease activity should also be developed. We also heard from Dr. Dodd, if clinical outcome trials are conducted using NITs, and if the observed response is durable and sustainable, and can translate into clinical outcomes, is what will make the NITs as reasonably likely surrogate endpoints. While all surrogate endpoints are associated with some degree of uncertainty, in order for FDA to conduct a fair and a rigorous benefit-risk assessment that these are predictive of clinical outcomes and not just correlations or association, they need to offer some assurance that after accelerated approval, they'll be followed through with a traditional approval. We were reminded by our colleague in OBGYN, Dr. Chang, who alluded what can happen, as was seen with Makena, if clinical benefit cannot be verified. The discussion concerning the imaging and the results, although encouraging, we still do not have data to demonstrate that these improvement in imaging biomarkers predicts clinical outcomes. At present, these imaging biomarkers seem to predict static clinical outcomes, but we need additional data that can predict dynamic changes that will translate into verification of clinical benefit. We heard excellent talks on imaging biomarkers, circulating biomarkers, NIMBLE update, and litmus update, and real-world use of these biomarkers. There seems to be some discussion regarding having a responder criterion for VCTE. We also heard numerous speakers that stiffness and fibrosis are not linear in relationship. What magnitude of change is required to assess disease regression is not very clear currently. For the circulating biomarkers, it seems that the data to support using these for diagnostic enrichment may be there, but adequate data for treatment response are still limited and need to be collected. Most of these circulating biomarkers are not sensitive enough to assess clinical endpoints. For most circulating biomarkers, we need data from the clinical outcomes trial. For longer duration, to conclude whether single or combination of circulating biomarkers can be used for assessing treatment response. Bioanalytic assay validation is necessary, as Dr. Kim stated, for all the blood-based biomarkers. Factors that contribute biomarker fluctuations, demographics, BMI, age, laboratory test, comorbid medical conditions should also be factored in. What we heard that the cutoff values should be harmonized and followed in clinical outcomes if NITs could replace current surrogate endpoint. Other challenge, if population changes, then a need to validate these NITs as surrogates to predict reasonably likely surrogate endpoint. In NIMBLE and litmus updates, NITs were compared with liver biopsy. However, the strength is that these data collection are very rigorous and long-term follow-up data are available. We heard both from Dr. Sanyal and Dr. Anasty that we need more data to show the extent or the magnitude of change in biomarker, that is, regression of a biomarker score, demonstrates clinical benefit. Global assessment of biomarker response, demonstrating both progression and regression of disease, needs to be shown, not only at a population level, but consistent changes at a patient level, and that should overcome the coefficient of variation needs to be demonstrated. We also heard that ballooning assessment is an issue using the current surrogate endpoint, which is a resolution of NASH or MASH. We will take this point in consideration and discuss this internally. In addition, DHN will deliberate discussions and other issues identified in this two-day workshop. We heard that the histology has a lot of limitations and challenges. But we also heard optimism regarding the use of NITs, including the use of artificial intelligence assessing liver biopsy. We heard about the knowledge gaps and limitations identified that these NITs to be followed for clinical outcomes. From clinical trials to clinical practice, we heard from Dr. Timothy Morgan about 9.5 million people in the VA system alone are expected to be at risk of MASLD, MASLD. Challenges in clinical settings include lack of enough GI doctors, and MASH will be primarily managed by primary physicians. Patients who live closer to smaller facilities in rural areas, lack of experts, lower resourced clinics that follow these complex MASH patients. Performing liver biopsy is not feasible in clinical setting. Liver stiffness-based assessments, VCTE has limitation including availability, reproducibility, positive predictive value, and negative predictive value in general population with lower prevalence of fibrosis, and technical challenges, operator dependence are few issues that he identified. Could ALT be used because it's inexpensive, it's ordered anyways and understood by most clinicians? Dr. Morgan emphasized a need to have blood tests to diagnose MASH, a need to have NIT to diagnose NASH with stage 2 fibrosis, and how to identify which patients need treatment and how to monitor improvement, lack of treatment response are areas of future research. With this, we conclude today's meeting. Thank you for sticking around until the end.